us to understand it deeper so that we put entire organizing committee and all the stakeholders and all those people who were able to make it to this place. Father, we thank you for the funds that has enabled us to stay here up to today. And we know that you are going to take us safely to our various destinations tomorrow. We thank you, Jesus. We ask you to bless us as we shall be coming to various places. In the mighty name of Jesus Christ, I pray. Amen.
Thank you very much. The departure is on Saturday morning, not tomorrow. And we guide and advise people not to move in the night. Thank you very much. Because the Honorable Minister will close the session on Friday. So don't move away as the prayer said. Okay, so thank you very much. Still, I welcome you to the 3rd Annual Community Health Partners Retreat, Day 4. I appreciate all the contributions and all the discussions which were done previously. And I also thank you in advance for the preceding discussions which are going to come. Today's day is going to be graced by the Honorable Minister of Health, Honorable General Thatcher. We are also going to be graced by the Honorable Kalisa, the head of PDM and the PDM Secretary of the Ministry of Local Government. But inside the house shall also be having the Acting Director General, Dr. Olavo Charles. We shall also be having the Director of Public Health, Dr. Daniel Charainze. We are also expecting more other participants to join us. And as they join us is when we shall do the reprogramming for the pedagogical aspect. But before that, we are proceeding with our agenda for the day. We have had so many discussions, so many contributions, and the participants are still viable to make more contributions. We have a team of rapporteurs, and I request kindly for the rapporteur who is present to give us a recap of day number 3. Over to you.
Good morning, ladies and gentlemen. All protocols observed. We are going to go through our recap of day 3 yesterday. We had a panel discussion on deepening community health, and we had representatives from Strong Minds, we had a representative from Mother to Mothers, we had a representative from Motor Hospital, and we had a representative from Mama Africa. And this is a gist of what was discussed. One of the discussants, Dr. Lydia, in her capacity of leadership, discussed strengthening partnership and delivering impactful health intervention through collaboration with civil society and community organizations. She emphasized the critical role of Mama African HICA in steering committee in advancing community health. We also had a recap from Brenda Nakanwaji, the senior community health leader from Ministry of Health. She shared the progress on the national community strategy, having interventions such as the CAST Plus and the TB program. We also had a presentation from the Principal M&E of Ministry of Health. It emphasized the key sector indicator performance. However, in the subsequent annual conference, all indicators should be tailored to community health. We also had a representative from OPM. She encouraged us to focus on measurable impact activities. Then our chief guest yesterday, Dr. Diana Atwine, the PS of Ministry of Health, she emphasized high activity impact activities. She noted that we need to strengthen implementation than over developing guidelines. We need to track on interventions in the field by choose VHTs and number of parish committees by parishes. The agenda meets the nutrition component by district representation, civil society representation. We should have had malnutrition as a theme, especially for Karamoja and Tororo. Presentation on jiggers, open defecation, set up backyard gardening, great nutrition days. Basically, we also need, it was emphasis on reducing guideline infestation in the coming year. There's also a linkage that has to be seen from Ministry of Health to the district, to parish, and to the community, and to household level. Thank you.
Thank you very much, Rapporteur. I urge the team which is going to welcome the Minister to lead the standing. And we do what we discussed. They come for breakfast. So Roger Paul is an investigative journalist and public health community expert, specializing in health policy and advocacy. He has a niche in TB and in community interventions. He is a researcher. He coordinates a group on imports. Paul is the director of CAL Consortium. Paul is going to give a presentation of civil society plan for integrated community health service delivery. So I ask Paul to come forward. Thank you very much. And I ask the IT team to shoot the presentation.
Good morning. Maybe what it is not mentioned, also everybody is profit. This is nothing like that. Good morning once again, what my name is actually the National Coordinator of the CAL Consortium, which is now country-wide, so they have a community-based organization, which is also nearby some studios. Anyway, am I supposed to control it for me? Someone is being next. Yeah, that's about civil society, as you see. All the civil society. About civil society in Uganda. Civil society organizations and NGOs play an active role in Uganda, approximately that number. They are registered, they are ready to provide different services. Advocacy, government, human rights. Society has the power to influence the actions related to promote leadership, accountability, good governance. Good governance. Among other tasks, CSOs will assist in working with government with integrated evidence-based planning, participation of civil society, inclusive government processes, more as possible. And placing control again, improving service delivery by holding the government and private sector accountable for good service delivery. As you see that illustration, the needs to partnership involvement, raising awareness, capacity building, and social accountability. Civil society focus on very community service delivery. Slide position also focus on public primary care as a priority towards achieving universal health coverage and SDGs, some SDGs in general. The past specific community integrated systems is directed to universal health coverage. When we talk of integrated service, what we are doing here, what is our daughters here, we are all working towards universal health coverage. Community-based primary care provides a sustainable pathway at this country pursuing universal health coverage and attending university, preventive, promotive, curative, equitable access, I go to primary care. It also delivers the community level offer, and offer the high return on investment and equitable approach and integrated services that address multiple health needs, equity and equitable focus. Disease violence, right? I'm not using the combatants. The granted is characterized as you see, except over the past 2 decades, again as grown up, you see that reducing maternal mortality from that to that. However, studies indicate that more than 75%, this is very important to note, of Uganda's disease burden is preventable and could be avoided at the community level, making the community a priority stakeholder. That's the demographic profile of Uganda. Why community-based primary care? Recent medicine such as the 45th anniversary of animal declaration and the 2013 Morovia broadcasting emphasize the importance of these initiatives. These stakeholders, global partnership and country commitments are lying around PHC, offering a unique opportunity to strengthen community-based efforts. These stakeholders also global partnerships and country commitments are lying around PHC, offering a unique opportunity to strengthen community-based efforts. By referencing these commitments and partnerships, kind of make focus towards universal health coverage, as I told you, that's why we're here, and the SDG. There is need for CSOs in health, especially, to refocus on strengthening community health services delivery partnerships. This requires taking advantage of the national community health strategy and existing structures of TRUES, PDC, and VHP through innovative approaches. So the structure is there already and and this why community PHC we are pursuing. TRUES are pivotal in advancing PHC. They contribute to prevention, inspirations, and create more equitable resilient health systems. Their valuable contribution of CSOs provide substantial return on investment in both financial savings and life savings. We launched at the World Health Summit in October 2023, a community service delivery partnership. Brings together countries, donors, multilateral organizations, CSOs, support national governments, fast-track actions to enable a more resilient, integrated, and efficient supported community workforce with best rights and protections. This is very clear here, but those are summarize the community partnership terms of what is it? It's very clear, and there's global perspective and community partnership approach. Purposefully built upon the Monrovia Code of Action, as I've mentioned, recommendation for greater alignment through the country-led one plan, one budget, and one implementation approach. That's why I think the ministry is going. More specifically, the community's delivery partnership approach seeks to add value and support country-led needs and priorities through including alignment, the country-led one plan, one budget, one implementation approach, strategically focused to increase political commitment to PHC. It's very important. With a focus on community level. Tailored actions to improve equitable access, high quality PHC at community levels. Stringent accountability partners through use of data monitoring and evidence-informed decision making and planning. I focus on life nature to evidence-based, to be evidence-based, and from bottom-up, bottom-top approach. With government in the lead, communities, delivery partnership, that's what has not come it's not from. It's not yet as in terms of community service delivery partnership, but it's the same thing. Partners will support, through that, partners support context-specific approaches using the best available evidence consisting of data and knowledge to inform policies, strategies, and actions to strengthen and build more responsive and resilient sales systems. Underlying committees for delivery partnership, country-led approach is a commitment to shared principles and an equity-focused gender transformative and human rights approach programming in order to improve health and well-being and enhance progress. You see, every slide talks about equitable, rights-based, gender-sensitive. Those are very, very important. Those are the shared principles of committees service delivery. The center piece of country-led, has to be country-led. Then it's system focused, equity focused, rights-based, gender transformative, context-specific, and evidence-informed. Under country-led approach, the commitment shared principle was of across the community. The pathways to positive impact on the related community is delivery. The collective expertise and resources. I'm speaking to all key stakeholders, civil society. We are supposed to, as civil society, we're supposed to work with the live industries and agree, like yesterday, it was talking about this zoning of partners and knowing who does what, where, all those are increasing partnerships. Driving towards that one budget, one plan. Civil society plan integrated. Although it has been noted that some reasonable degree of integration has been achieved, yes, some degree of verification still exists, verticalization still exists. For example, malaria control, HIV, post-immunization are relatively still delivered vertically. It has been noted that more effort is required to integrate service delivery, especially at operational level. That's why we're here. Because section of CSOs focusing on health in Uganda has embraced the use of the integrated service delivery roadmap that has vigorously started with the first-class initiative that is looking at TB, HIV, malaria, WASH, immunization, and nutrition. CSOs realized the vitality of reducing fragmentation and aim working with silos. Very important. There are a lot of CSOs in universal health coverage beyond service delivery. I've told you that here, our mother here is universal health coverage. And we integrate, we do everything, but work towards that. Civil society has a role to play in all the 3 pillars of universal health coverage: case financing, service delivery, and most importantly, good governance. CSOs have always played a vital role in health service delivery, the wider document and should end. Still, civil society needs to engage fully in advocating for more funding for health and universal health coverage policies that are equitable, inclusive, and evidence-based. This can be done through budget advocacy. To be truly addressing community needs and profile priority, decision makers must facilitate the participation of diverse civil society voices, especially those from marginalized populations, to strengthen the narrative of health equity. It's very important. The other slide was about important civil society. Importantly, civil societies can act as a vital bridge to build community linkages, collaborate, and coordinate with other health actors. That's the role of good system governance. Schools communities play a vital role in government, accountable, accountability commitments, and health process and programs are inclusive, again, equitable, responsible for. That end, CSOs at global level convened by civil society engagement mechanism for universal health coverage 2030, and partners developed the 4 advocacy in the lead up to the UN level meeting for universal health coverage 2018, complementing the specific commitment areas of the key asks to build universal health coverage movement. These key asks are core requisites for governments and political leaders to take action on universal health coverage. They were created collectively by a range of health and other stakeholders worldwide, including parliamentarians, civil society, private sector, agencies, networks, academia. Those are the key asks. So political leadership beyond health, leave no one behind. There's a legislate and legislate, uphold quality care, invest more and better, then move together. Gender equality, fairness, contribution to strengthening. Now we are going to consider contribution to strengthening community systems. The contribution, of course, was raising voices of affected populations, individual populations, drive research and data analysis, and technical systems. The main objective communities are the same of this approach. This was in partnership with the ministry to focus on community case, the health system strengthening, guided by appropriate health system building blocks through leadership and governance, service delivery, workforce, management information systems, financing, and community engagement. On these building blocks, of course, they are priority building blocks where CISO has focused the pillars. The role of social case financing industry components for more funding, for labor strength, and so on. Social determinants of health are addressed. We have also to look at the cause of illness, to look at monitoring health expenditure and hold governments accountable for commitments, and mobilizing communities to increase demand, reach those left behind, service delivery, expanding the range of services, providing integrated person-centered care, training health workers on how to work with marginalized communities, improving part of care, including the AAA2 framework. Then governance is participating in policy and budget decision making, holding governments accountable for commitments, advocating transparency and access to information, ensuring universal health coverage policies are equitable, inclusive, evidence-based. Okay, you are there, the word equitable, based, patient-centered, and that's the way. Let's commit and patient. You can see this political flow. Talks about the living blocks, the service delivery, and the criteria to access, quality, equity, leading into responsiveness, and risk protection, and disability. Focus on the three primary care components. Meeting people's health needs through comprehensive, protective, key health services. Systematically addressing the broader determinants of health, including social and environment factors and welfare. Empowering individuals and families and communities to optimize their health as advocates for policies that promote and protect, for policies that promote and protect their health. Community system for health promotion and prevention that's forecasting. The better service delivery model is an innovative and new approach to service delivery and will require careful change management. That all stakeholders fully understand the approach, their roles, responsibilities, and commit to making it a success. This was the embracing pillar 4. This was embracing pillar 3, 4, and 5 of the integrated service delivery model. Those are the benefits and results of the integrated service delivery we're talking about. The jobless, rules, elderly, sick, people living with disabilities, women, unskilled, disabled, households, children, community service delivery platforms, like I said, allow for the sharing of resources, expertise, and strength and community systems, which should be a primary focus of CISCOs, everything, silos. Currently, the Uganda community service delivery platforms include ETS, living goods, Intra, smart health, and the CCP program, price-based education and system-based orders for work and so on. So the CISCOs are supposed to be cognizant and focus on these delivery platforms, service delivery platforms. Key, the CCP pillars, once again, the role of society. Some CISCOs that need to be active at all stages in designing, implementing, monitoring, and transforming health policies. The PES was saying yesterday, then we need an agenda and all the stakeholders participating in the agenda so that we give our something very important. In particular, CISCOs and health networks have lived experience as people living with health conditions as any years of health systems, despite in people. expertise in people-centered and community-led health systems and approaches, including integration of health services, ability to reach the most vulnerable and marginalized populations, strong commitment to equity, human rights, and inclusion, key data and information on health systems and workplaces, experience in health monitoring and accountability mechanisms. All those are pillars. The year practical declaration in 2019, number 2054, reads, engage all stakeholders, including civil society, the private sector, the academia, as appropriate, through the establishment of participation and transparent stakeholder platforms and partnerships, provide input to the development, implementation, and evaluation of health, social-related policies, and to review progress for the achievement of national objectives for universal health coverage. I hope all these are here. Then what? Elimination of working in silos, reducing duplication and fragmentation to ensure value for money and strengthening partnerships with the respective line ministries and key stakeholders through MOUs. Instead of coming up with activism to say the national communication maybe has left out these and that, I think that's the best goal, but let's focus on MOUs and partnership building for service delivery, and we shall really achieve the aim. Mobilization, mapping, profiling, and building capacity of CDOs, choose BDCs and BHTs, in order to increase ownership, demand, and utilization of community integrated services. Living goods, if it's living goods in the room, I think. So it's doing a good job in the area. Reduce the baptism of, this is the baptism of community workers by different CSOs and partners that has been rampant with definitions like community facilitators, community delivery, drug delivery, whatever. It is, there are many, but there are some people. So today I think I embrace what came up, because the National Committee Health Strategy is coming up with VHTs and choose. So that whoever is working, going to work, that's the one plan that about once the VHTs, and they are all, they no longer have different people with different titles and they are the same. That's what is aggressive addressing. So you come and kill too many birds with one stone. So let's reduce that. According to the recent National Mission 24, still has a big, Uganda still has a high value of preventable illness that involves already mentioned high treatment costs and already constrained resources. Those are all sure and fun. It's estimated that 60% of the mortality in Uganda is due to preventable conditions, yes, according to robust innovations for behavior change among the population. Advancing life protection and health systems integration. Uganda has achieved parallel shift in PHC level by categorizing choose other formal committees workers with guaranteed minimum wage as well as VHTs who are key activity-based players. This also suggests more coordination and collaboration with this. Then invest in and expand community health worker data collection and analysis, including community health worker master lists and registries, apply a gender lens to community health workers policies and support more gender transformative approaches and program design. Extend educational safety, health guarantees, social protection, expand formalization tools to base a country context, conveying formal rights protection and remuneration. Support financing plans and budget advocacy for community programs. Foster funding transparency among donors and to share investment information as possible. I'm speaking this for strengthen country coordination forums, tools, and regular processes for transparency and alignment of activities and funding for community health. Expected result. What does success of engaging CSO, CDOs look like? By the way, we talk about CSO, CDOs, of late I've realized that CDOs, they end up being the whole road to really CDOs, community-based organizations, because as I tell you, as we conclude, they play a bigger role. Several studies have shown that involving social and community in the design and in advocacy and governance will lead to programs of services that respond to community needs. That's our superior focus. Reaching the most vulnerable and hardest hit communities, increasing community demand for health services, evidence-based decision making. As I told you, cannot make any decision without evidence, and evidence should be bottom-up approach. enhancing monitoring, database and accountability, with domestic international for program sequence, of health outcome, building community-based ownership, design, all those are indicators of success that CISCOs are doing on cable. Now I'm going back now. We can move now from the CISCOs to start perspective to integrate our focus on policy aspects and system strengthening. But now I'm getting the carbon consortium now that could provide governance, coordination, and coherence across the RKN's regional car networks. We have regional car networks and district car networks that formed for 1 year now. We're now covering the country. Use the regional and district structure to through a CSO stress engagement of tools, PDC and VST. You have to work towards what's now in place and try to, like the PSC said that this look at gaps. What are the gaps? Then look at what failed and why it failed. That calls for this. Improve livelihoods of rural communities through financial literacy and linkage to microfinance. Because we can talk about everything without sustainability, without livelihoods. Support formation of community advocacy platforms. I'm talking about where the consortium is focusing. Strengthen linkages between district groups, local governments, and district car networks. The community strengthening of advocacy platforms were mentioned by Global Fund so many years ago. But all players have been linking out that aspect. It's very important. CISCOs need a paradigm shift from the intermittent radical skepticism activism. It's very important, listen to me. To harmonize collaboration with the line ministries looking for this. Because when you go into activism, you cannot receive much, but you work with the line ministries, be able to identify what are the gaps, what has failed, why has it failed. By that, the CISO will do a very, very big major contribution. Promote advocacy and raise the profile of the national committee strategies, committee programs. Sensitize communities on the roles of this is the consortium focus, structures and workforce, and empowerment of communities. The newly formed consortium is that, national consortium that started last year, with mapping and profiling of 400 CBOs in 40 districts, expanded 800 districts, with 8 CBOs in the districts, and now cover the country with 1,350 CBOs focused on one district. The consortium has formed district and regional car networks, so that will be focusing on the taglines, championing integrated service delivery, with the goal of strengthening community integrated health service delivery by making CBOs the custodians. The car consortium, in partnership with the ministry and the private stakeholders, aims to champion integrated service through the adoption of the national community strategy to build an integrated, equitable, and efficient community system that potentially embraces the AAA framework. Stability, affordability, framework, which is very, very quality framework. To ensure a comprehensive integrated service delivery that feeds into the cost model, to ensure you see by making the community become the custodian through community monitoring, which is still hanging, it's not yet ready. After the mapping and profiling of CBOs with accreditation by district local government, CBOs organization capacity followed was completed followed by online capacity combined with formation of these CBOs into these car networks. In some of the car networks, I think we're about to see here, Hitboom, Bucho, and this being followed by the formation of these local networks. And coordinated networking for impact. The capacity building model has changed from virtual to physical due to internet access constraints to a larger proportion of CBOs that cannot sustain documents. Currently, the consortium is switching to a tilt model where regional entities are being trained to train the district CBOs with TF of the consortium secretariat. That's the maritime model. The green is the consortium of the consortium in Uganda, then the blues, regionals, and the team, the district network, but they also go to the another car that goes the county Alice village. We will not put all that in the same, but from being now we go sub-county Alice village. That's the maritime model. engagement with Ministry of Affairs. We have engaged with full engagement with media efforts, guidance documents, DHI, malaria, midterm reviews, and national strategic plan involvement. We are there to just take order virtual meetings with Ministry of Affairs respective divisions. Thank you, Edward. Edward is always spot on. He knows where to go. And we will engage. But especially in the MAF-TB consultation at country level, we did a lot of this. Engagement with committees, implementation committee, Ministry of Affairs, engagement with WHO country office, but especially very engagement in working group. I consulted work plan 24 with the mapping, profiling, and implementation of CBOs in 135 district that's done. Organization capacity assessment for CBOs, ongoing, capacity building webinars for district network and digitalization of database, one impact CM, artificial intelligence engagement, ongoing, operational regional networks and partnership view, allowing benchmarking. We're getting a benchmarking here from Zambia and Tanzania. We have a national platform where they're trying to look at how we're doing it here, so that can be the state can be replicated in this country. Then capacity building for regional networks through model, scaling district networks, ongoing like I mentioned. Then roll out of a similar structure to SKDC designated countries. Highlights of completed setup activities, mapping of CBOs and needed transformation, TIC, organizational capacity assessment for CBOs, done, TIC, formation of local networks and allowing benchmarking by TIC, work plan priorities, secure funding switch from virtual to physical capacity building of regional networks through a joint model, provide governance, coordination, and coherence across the regional networks, use regional structures to ensure alignment of the district network, choose RDC, PDCs, and PDCs, improve livelihoods through financial interest subsidies, support formation of community advocacy platforms, strengthen linkages between district local government. We are saying, I've been addressing this country wherever you guys say, we should empower the CBOs, CSOs at sub-national level to be part of the district planning and budgeting. And the districts are very willing. So that the primary health care envelope, which our telling commissioner, sir, the chief about it, how much does it goes to PCs in that envelope? Is it enough, or is it a situation whereby you expect them to do so much, so little? So that's partly part of engagement. Establish a robust community monitoring, support the rights-based people center that has been a theme announced today, the gender sensitive approach, to ensure an effective and efficient people AQ framework, which will highlight some district networks like bigger and the bigger and the Doro, that's why those are our current networks. Way forward, focus on way forward. Empower community to take lead in making decisions about their own health. This is what we're doing. Raising of awareness to enhance behavior change. Support advocacy through identification of community needs and supporting members' demand for quality and equitable health services. Invest in an integrated, equitable, and efficient community health system. Prioritize community-led monitoring the integrated community health service delivery. Focus on some of the components of the Uganda National Essential Health Care Package 2024. Strengthen SCSM for the social determinants of health. Let's look at also the cause of the illness. Then conduct advocacy, communication supervision for health equity through a patient-centered and rights-based approach. Prioritize male engagement with TB HIV. It was discovered that TB is 4 times higher in male than the female health service, and the need for the design of male-friendly services that can attract the utilization of and association of TB services within the facility and communities as well as the child. The SDGs set out a broad vision for the future, and women, people with lived disease experience, children and adolescents must be at the heart of efforts to achieve that vision. Social engagement, the ISD narrative, ISD is the better of delivery, is essential for meeting common goals for accessing progress of women, children and adolescents, particularly in reaching the poorest and most vulnerable. With this national committee strategy, civil society is poised to contribute to strengthening the integrated committee service delivery processes and results, including stronger plan implementation and accountability. Thank you, asante sana for your attention.
Thank you very much. Maybe you can be having a seat there. We are going to enter into the Q&A session. But I request when Honorable Minister allows me, I will disrupt the Q&A session immediately, and then I will request you to stand up. So we are now in the Q&A session. If you have any questions, any supplements, civil society organizations, CBOs, you can just raise up your hand. I urge my ushers to be ready with the microphones and the sanitizer as well. Very good. Okay, there is a microphone here. There's a hand here.
Okay, thank you so much. Roger, thank you. That was powerful. I really appreciate your work and the fact that you're passionate about TV. We were with you in one of the board as board member. I was a board chair, you were a member, a treasurer, I think. So I think that's good that you're pushing the agenda forward. My only concern is, in your presentation you're talking about civil society. But in this country, I know we have very many partners, very many organizations working in the area of health. Is there a mechanism that we can have all the civil society in one coalition? I knew we had one that was responsible for family planning called the Uganda Family Planning Consortium. And all partners that were working in the area of family planning subscribed to that. Now, when you're talking about the civil society, my mind is wandering. Have you catered for all the civil society in Uganda and give their representation? Thank you.
Okay, very good. Have you catered for all the civil societies in Uganda? Yeah, taken that question. Yeah, you want to answer that immediately?
Thank you, Dr. President. Yes, this is right, but there's also another book. My presentation also looking at CSO integrates, focus on integrated service delivery. But honestly, I think there was less consultation with other civil society input and agree on that. But another thing also, what Dr. Rosen mentioned about the coalition formation and body that can bring more civil society together. That has been a challenge. A challenge that led to me actually us coming up with this consortium. Because when we are starting this consortium, we dived into a network and we got expert opinions from different stakeholders who called us for a meeting and say, you know what, this cannot be a network at national level because networks today, like Edward mentioned yesterday, that there are some organizations that are working on one household. So they said networks now are seeing people come and form a network, so networks have lost the credibility. So we looked at a consortium and then set up networks of CBOs at regional, at district level, and then we get a regional representation for those district level community-based organizations. So Dr. Rosen, it's a challenge. That umbrella is a challenge. Remember very well the umbrella where you and I were board members, which I may not mention here. That challenge is up to now since it's going towards the bottom rock. So yes, and civil society, to be honest, as I told you, I'm a man of God as well. I like saying the truth. In civil society, we have challenges the harmonization is a bit not as one may imagine, because For example, when I was invited to come here, I've been receiving emails, how are you there, Roger, we invited you, how about how come other civil societies and on. But I was invited because when I started the consortium, I realized the first key stakeholder was the Ministry of Health. So I came to the community department, I went to all the respective relevant departments, and so to have MOUs. So they know, so the Ministry of Health knew about me as a partner. So the zoning, I went to the zoning that was being displayed yesterday because we're just a new consortium trying to do that, but we're going to the zoning again. So there's a challenge in forming that coalition, and I don't know who can be. Now, for example, my already asked about the coalitions coming out and HIV, the same thing. So the coalitions have one umbrella for all the skills. It's a bit of a challenge, but it requires harmony and stakeholder engagement and more consultations. Yes, my CSO focus here has been on integrated service delivery, on the outcomes of the community department that we've been engaging with. So I was talking in that perspective, and not entirely on the entire civil society. I wouldn't say that, but in the perspective of our relationship with the various committees, departments, and ministry. That's what I was sharing. That's our integrated service delivery focus on that.
Okay, thank you very much. I need the microphone there. Yeah, yes.
Thank you very much, man of God, for that presentation. I have got 4 concerns. You being a man of God, how are you trying to address the ethical issues in the arrangement you have? I feel ethically we are not addressing issues as it's supposed to be in the societies where we are, more especially in the institutions where we are here. Are you doing something about ethics? That's the first question. If not, then we can come in and share. The other one is, you are talking to, communication is all about understanding. And I believe not all of us here are health workers, doctors, others are people who may want some information. What do you mean by, I was reading something, 506 per 100 live birth? How would you communicate that to a local person if you are trying to communicate so that they understand what you're talking about? And the other question, this is a general question, how far have we gone with SMGs? And how much time is still remaining? Are we still set? The last question is going to be, another thing I've seen and worked with civil society is integrating budgets and MOU. You can squeeze a stone and get water than saying it's civil society organization to bring a budget and an MOU in the local government. What steps are we taking to say that we work on that? Because I hear that you've talked about one budget, one plan. We can't do that unless that is done. Thank you very much.
So you can squeeze, it is simple to squeeze water out of the stone. You can get in the budget from CSO. I use that in that one.
Thank you very much. Let me take you back. You said SMEs. Your question on SMEs.
So can you clarify your question on SMEs?
As it is moved up.
Yeah, moved out immediately. Yes, question.
Okay. Thank you very much. The addressing of ethics. The guy just confronted my religious that I'm not talking about ethics. Ethics, the ethical issues are very complex. Yeah. Delivery, we have online, we have society issues. I think not to go to extremes, but it's really contained in every aspect of implementation. In the members' perspective, they now advocate for the rights. Every slide of mine was talking about rights-based. And it's other issues, what those are given for. That's why every slide, my brothers moved out there, you think the one coming? Every slide in this, that. The epidemiology issues, I think it had been a source from the Uganda National Essential Healthcare Package. The epidemiology issue you talked about, so you can go, since you have it online, you can go and consult that page. So online about your question, you find the answer there. SM is, did you come back? I want to name SM is.
Can you clarify your question?
SM what? Which one?
Sustainable development goals.
Sustainable development goals.
Yes, those are SDGs.
But you were present during my presentation because I was saying I didn't want to preach the converted, take everyone through the sustainable development goals, but we're working towards sustainable development goals, specifically some 3, 4, and 5, and others. When you go broadly, there are many, but they are really contained in every, I can mention SDGs.
My question was not about it, it was just how far have we gone and how much time will remain.
Yes. Sustainable development, you see, we have had targets of 2030, we have focusing on 2030, and some have also gone to 2040. But so far, I think so good. SDGs, we have worked towards that. We're looking at 2030 and 2030 just a few years from now. So far, as various and what we are achieving the 95, 95, all those are feeding the SDGs, but so respective SDGs 3, 4, and 5. So the issue of, I wouldn't go into the issue of SDGs, but we're working towards Uganda and the rest of the world are working towards that. And I think we are doing out those, I told you, like the epidemiology question you had. You go to Uganda, visit the Uganda National Essential Healthcare Package 24. It has that information very well put. Because presentation was very clear here in this slide. You get the answers to that. MOUs, this is now what I'm interested in. These MOUs, they talk about one plan, one budget. That can be achieved. I don't know if you are civil society or I don't know. Are you civil society?
Person. That's 2 persons.
Okay, but this one plan, one budget is what we are looking at to avoid, we have a fragmented approach, vertical programs, duplication. So I now want to focus on one thing. That's why I think the government has come up with a structure streamliners. Work with choose, work with VHTs, PDCs, up the household level. Because these VHTs lead you up the household level. We're trying to have one plan. The question is like the piece I think was saying here yesterday, I got it very clearly. Share what we're doing, let's know where you're failing, let's know the gaps, and we sit together as a team and see how we can address. That's also one thing I've relatively realized that you can also mobilize resources working together as the line ministry of health. You work together to identify a common barrier and mobilize resources. Because the government doesn't have such an envelope that can reach every Ugandan, every citizen. So there's one budget, one plan is going to come out of partnerships. In my slides I mentioned MOUs, I kept saying MOUs. That's how I was responding when the president this question. I was saying in my presentation I did not say I'm representing civil society in Uganda, but I'm representing my relationship. I've worked with the Ministry of Health to start an MOU, work together. I've seen the challenges. My presentation is full of the national competency barriers, focus, approach. So that's how it gave birth to this presentation I was making. And that's the way we should focus. So with those partnerships, we are going to achieve that one budget, one everything at the center.
Okay.
The center.
So thank you very much. So there's a question there, Madam from Capelabio. Will you introduce yourself? You are from Capelabio?
Yes.
Okay, can you introduce yourself?
Thank you so much. The protocol. Good morning, everyone. My name is Abdina Mrizamo. I work for TEWEDO, the Women Empowerment Development Organization. It is a CGO from the Capelabio district. I'm here. I'm happy to be here. And I have two things I wanted to raise on the CSO. One, like it was yesterday's presentation by the person representing the people of the PWDs. I wanted to find out what approach, what policy do we have to say that these people living with disabilities are included in our programming. To me, I have an experience. I have a person who is visually impaired, greatly skilled and having no opportunity of work. But whenever we always involve such people, we realize that they benefit us in the community. They always give encouragement to other people, more so the youth. When they see them working, they see if even the person who is blind is talking this and this and this, what about me? Can we maybe develop a policy whereby we say every organization, every CSO, please include 1 or 2 people living with disability in your employment issues. Then 2, I had a lot of consumption on a CSO. I've not been knowing that we have a consumption on the CSOs. I wanted to know which approach do you have, as in how do you map up the CSOs, how do they come on board, and how do you always make sure that you're in touch with all of them? Because personally, I'm not aware about it. Maybe I'm behind since I got the but we need to know what approach is that and how do we come on board. Because I have experience, I worked in a network whereby the coordinator gets a communication, mobilize this number of CSOs to come for an activity. Who will tell me, please write this and this and this. He will mobilize his relatives, 10 of them. And they will assign each one of them an organization. I did it by the order from above. Yes. They assign them the organizations, and these people go. And these CSOs are left behind, who are supposed to get the information and do the implementation. The wrong people are taken, they cost their money, they go back home. And this one, yeah. And this one is totally green, they don't know what's happening. So the CSOs remain green in the ground, and yet the regional team is really trying its best to see that the CSOs are capacitated. But wrong people are taking up. Thank you so much.
So can you answer this question? Those are very interesting questions. So can you get a question from Commissioner? You answer those questions.
Yes. Thank you, everyone. Thank you very much. You said you are from which district?
Capelabio.
Capelabio, you said.
You said no Capelabio. Capelabio is in district. Yes, that district after Soroti Amoya Capelabio. Yes, after Kata. That's zone.
Now, thank you to respond to our concerns. The current consortium, we came in a unique way, and this uniqueness was to ensure equality and address. We came up with our beginning of our mapping was focusing on 10 CBOs by district, and these CBOs were expected to have recommendations from CAOs and CDOs, from the CAO and CDOs, and that was followed by administration certificate. And after doing that by district, we went ahead from what's called a district as we sort of structure, a district car network. These 10 CBOs, after being accredited, they come together, they form a district car network. As I talk, we have about 3 district car networks in the room from different districts. From that stage, your issues of concern, of worry about how it's done, these I think are very transparent. All the district car networks, the CBOs we have, are known by the districts. Even the CBOs they are all formed chat groups. Each district, where a chat group, even they put a CBO on the chat group, so you can imagine the level of transparency and integrity in those networks. So we don't expect the CBOs Edward was talking about, that you find the CBOs for one household. Let us edit out that. Now from that stage, we have now developed terms of reference, having district car networks, nominating each district, each region nominates one regional organization that will be in charge of the region. They do it themselves, they nominate. It's a very, very active exercise and transparent. They nominate a regional that you saw in blue in the structure. The regionals, so we have about 16 regional organizations representing all those districts. Then we go ahead, we form committees and supervisory committees at the district level, and also those are our terms of reference. So the issue of briefcase CBOs, I'm not seeing that for us, we don't. My networks there, and they can say, agree to that.
For us in Cameroon, we are not seeing.
So now, go to Soroti. Soroti, what happened? We're using CAWs, CDOs to get us the CBOs, the 10 CBOs. That's the criteria we used. We never came on the streets to say, from the sub-count and look, ask villagers and which organization work. You know, we went the legitimate way through CDOs. CDOs move forward the number of CBOs that they believe are on the ground. Then we go ahead to do a due diligence to see actually if they are real ones. For Soroti region, we are already there. We have formed the Oreda is a CSO based in Soroti City. It has been given the slot of Teso region. Each region has a regional representative. So Oreda, I'll give you a contact of Oreda. I think we might have. He has already forwarded many in the database. I think he has covered most of the districts in Teso region. So I'll give you the contact of Oreda.
So you give us the contact for Oreda, because for us in Cameroon, I came with cow. Where's my cow for Cameroon?
I am here.
Yeah.
Yeah.
I came with my cow, with my share.
Yeah.
With my share.
Chairman, just got out of this.
Yes, to receive that call. So, get that for us.
I just wanted to make a comment as well.
Yes, we for us in Cameroon, we get a full team. So you give my cow.
Thank you very much, yeah. And the presenter. Actually, what my lady is saying is true. And she's saying it from the CPO point of view. Meaning it is true. You've talked about the cow, the CDO for worry. Me, I've not seen that list. And I want to say, I've been there coming to 2 years now. So I've not seen. And what I want to say, Kapeledion, like you did not know, is actually close to, is bordering a park. We should have been treated as an undercurrent model. We don't have the CSOs and NGOs doing massive support, which we really want. And I'm happy that you are here. WHO, I have just seen them popping in. UNICEF should be in, but we are there.
Even UNICEF is not in our place.
They are all the services. They are not doing much. And we want them first on the ground.
UNICEF is just in front of you.
My name is Robert.
Yes, that's my house. Now, this is waiting for my commissioner in the ministry. When I'm not with Capelio, I'm here.
Good morning, colleagues. Appreciation from the people of Capelio. You have preempted my question. And that brings me to the point of saying, I'm one person who believes very strongly in CDOs and civil society organizations. And I believe they have very strong roots in almost every part of this country. And the current move is to have our implementing partners, our donors, work through civil society organizations, build their capacity so that they are able now to deliver the kind of services they want to the lowest level possible. And I'm asking myself this particular question. After we have heard from Mr. Rogers as a ministry who are interested in working with civil society, how do we take it from here after this very particular engagement in this role? How do we take it up from there? Given the fact that we don't have one particular umbrella of civil society organization that can guide us through entering all the other civil society organizations. Given the fact that now we can see in Capelio, they are wondering how the civil society have already gotten into consortium even when they are not in some part of the districts. How are we going to look at this idea of saying, let's also spread ourselves, just like we are saying together as partners, we want to zone ourselves and make sure that even going virtually, you will say, if I am more in Soroti and I cannot be felt in Capelabio, how else can I bring other players who do the same thing like me to cover us in Capelabio? If we are more in Karamoja and we are seeing a lot more problems in Ankole, for example, how can we as a society together as one leverage our strength, resources and support to make sure we reach even Ankole, even when we are not patient in the country?
Very good. Yes, there are so many questions. Can I have UNICEF first too? Because we need this. So I will be, UNICEF, I will briefly instruct you, and I request for us to stand. But immediately she sits, we shall show our report. Welcome, Minister. You are welcome. You are welcome, Minister. Okay, thank you very much. I think now we are switching our discussions to a political ceremony. I will ask the IT team to give us the anthems. We shall begin with the Uganda anthem, the East African anthem, and then the prayer, and thereafter we shall go back to discussion towards capital bill. Behold, I will do a new thing, now it shall spring forth. Shall ye not know? I will even make a way in the wilderness and rivers in the desert. Madam Josephine, can you come and give us a prayer?
Good morning, Honorable Minister and your delegation. You're welcome. And good morning to all of you, my colleagues. My name is Dr. Josephine Pena. I work with Uganda Medical Society. Please let's humble ourselves and we pray. Almighty God, we thank you for this day. Thank you for it is yet another opportunity that you have given to us to work as stewards of what you've entrusted us with. That is the health services of this country. We acknowledge your supremacy over our lives and all that we do, for we are the works of your hands. As we convene today, we ask for your presence to be in our midst. Grant us wisdom, understanding, and the zeal to honestly work towards an integrated community health services, that the people of this country shall be healthy and prosper in all the spheres of their lives. In Jesus' name we pray.
You can take your seats. Honorable Minister, welcome to the third annual Community Health Partners Retreat. We are moving with the theme accelerating towards an integrated community health agenda. And in the room, Honorable Minister, we have Office of the Prime Minister represented. We have Ministry of Gender, Labour and Social Development represented. We have Ministry of Local Government. We have Regional Referral Hospital Directors. We have Chief Administrative Officers. Among them is Chief Administrative Officer of Kaperebio. We have Chair Council of Kaperebio. We have VHTs, Community Health Workers, HDPs, Implementing Partners, Commissioners from the Center, both in Ministry of Health and other ministries. While we are continuing with the discussion, you have also found us delivering a presentation on civil society plan for integrated community health service delivery in the communities up to households. And the discussions were going on before we had switched to the political program. And the discussions were focusing on delivery of services by CSOs and CDOs. We were tackling mapping and we had questions. Michael from Kaperebio was asking UNICEF a question and UNICEF wanted to respond. Now, before we switch to another Environment Affairs Commissioner will come, I want to discuss that question. UNICEF, you have a question. And I shall give UNICEF a microphone. Very good.
Thank you very much, and good morning, Honorable Minister and Director. We are happy to be here. While you were away, we were discussing the issue of CSO coordination and aligning to one plan and budget and one framework. And Kaperebio was complaining that a lot of partners are not favoring their district, including UNICEF especially, except in EPI. And this is what I have to say about CSO coordination. Knowing that it's a bit difficult for CSOs to have one umbrella body at national level because they are simply too many. And we've had the LACEs, we've had CSOs coordinating in HIV, various CSOs have come together, but the overarching is very difficult. They were complaining that Paul does not represent all of them. I was thinking, and I wanted to throw it back into a cow's basket. At district level, as a bare minimum, could you please coordinate all the partners in that one plan that you develop, so that you know who is doing what, where, and with what resources. This will minimize the level of duplication and encourage synergies. At least if we can achieve that in the 146 districts, the locality will grow up. And then we'll see which districts are offering CSOs and CDOs, which districts have too much concentration of partners, and then the ministry can actually direct right? Have a map to direct who should be doing what where, because this is best on need. So that's the kind of map that we'd like to see going forward. But it begins with the leadership at the district level. So thank you, Uncle.
So, Michael, it begins with you. You have to reach out to UNICEF and to the Ministry of Health, right? Okay, we shall have subsequent discussions. Honorable Minister, now I call upon Commissioner of Community Health Department to come and take over from you.
Good morning once again. Our chief guest, Honorable Minister of Health, Dr. Jeremy Action, the PS Minister of Health was here with us yesterday and has asked to be excused to be away. Our Director General of Health Services is already coming. I hope he will be here with us very soon. Director of Public Health, Minister of Health, Health Department partners here present, Office of the Prime Minister, implementing partners, commissioners and directors from Minister of Health and all the senior officers of Minister of Health, directors, commissioners from other areas, civil society organizations and CDOs here represented. The academia, our community workers here represented by the various cadres, including the community extension workers, graduated teams, invited delegate participants, ladies and gentlemen. Honorable Minister, it's my pleasure first of all to welcome you on behalf of all the participants here present. And also to say that we as Minister of Health, we have also come here as mutual partners in this very program. This is an organization or a meeting of people we have called partners in the community space. And so this is our third all partners retreat. Honorable Minister, I am happy to come on the fourth day. If you had come on the first day, all these partners out of excitement will walk away. Because you missed the first retreat that was in Calabar. You also missed the second retreat. This third time they said they will sit here and wait until you are here. And I want to thank you. Others have questions they have been gathering all the years they have been in the health space. Others are saying, we want to touch this minister, even for once like this. We are praying that your security details will do all what they can, but give us time and space to interact, engage, take selfies with this. They want out of love. Our first retreat was in Kalangala. That was in 2020. Honorable Minister at that time, we wanted to know who are the health partners in this space and how will we leverage on their strength, on their resources to advance community agenda so that we are able to take services to the grassroots. Through that first engagement, we happened to pull through the first national media strategy, which everybody launched, and we are very grateful and we are honored. Honorable Minister, the second retreat was in 2023, again in Kalangala. That retreat was basically to say, now that we have known ourselves, we have known our strengths, we have known who we are, how can we come together as one, grow up synergies, and also see how together we can strengthen the community agenda now that we have this strategy. But of course, the strategy was telling them the story of how we work to build the community systems which are actually the six WHO health system building blocks. That was the idea around that. This particular one, Honorable Minister, it came at the right time when you launched the National Essential Healthcare Package for Uganda 2024. Out of that package, there was another smaller package grown out of that, basically to focus on community health and household level delivery services. And so as we drove in through the main gate, Honorable Minister, we saw all those banners speaking to which partner is there in this space. And so we say these partners will together, after this time now, tell us, interrogate ourselves, how do we together now deliver this essential healthcare package that can speak to every member of the household along the life course cycle. And that's the reason we are here, Honorable Minister. We are interrogating ourselves, we are looking deeper into the achievements we have made in the past and also in our failures, and want to come up with answers. And we know for every question under this space or under this planet Earth, there is an answer. Because where you cannot get the answer as a human being, God has said He has the answer. That's why this answer to your question. As God has, our Honorable Minister, who seem to have all your answers. And that's our happiness today. And in this country. Honorable Minister, when you took a deliberate move to say, we are not now going to remain in the facility service delivery platform. We must enter the household. You came up with the National Health Policy trade. We said we are going to actually embed community health service delivery in the already existing service delivery block, which are there in the you can see in that concept framework to the national health system for Uganda. It requires that if we are to deliver services, to bring household production of health, we need the community-based health promotion and health care. That's why it is embedded in the health service delivery pillar. The next pillar we talked about health workforce. We discovered that in order to deliver this service package, now we are talking about, you need community-based trained health workforce. This together with the societal partners, together with community organizations, including community health volunteers, we can tackle even the social determinants of health and be able to create a healthy people, healthy communities that contribute to the social transformation of this country. And that's how we say we will together as partners see how we can actually deliver this national health policy agenda for the country. How do we deliver it? My pastor there, just give me one slide there as a summarize. IT, that particular one. Again, this one is drawn from the Uganda National Essential Healthcare Package 2024. How we have structured this country, particularly the health space, to deliver. And the structure of Uganda healthcare delivery system dwells on these two platforms. The central level ministry of health and affiliated institutions. And there you see, starting lower down from the regional hospitals, the national hospitals, and the national specialized hospitals. And we are saying these institutions can only function very well if you have a very strong local government health system. And this local government, whom we have called to represent other local government members and leadership here, we wanted to tell them that as Ministry of Health, we have done our part. We have given you the structures, we have even given you the resources. we now want to pick it up as a duty and a right. You also have players like the private sector, you have the private hospitals, the private pharmacies, level 2 laboratories and rehabilitation centers. Again, you have other 9 ministries, including other players like local leaders, like other community volunteers, like other institutions within the community. We are saying all those are at your liberty. Use them. You don't need to ask for money from elsewhere. You have the money. All these partners here have shown enthusiasm in trying to make sure that the local government health system function in this role. We want to liberate on the parish development model, social services pillar number 4. And there's the more reason we have office of the Prime Minister, also local government secretariat of the PDM here to guide how do we leverage the structure already established for us at the parishes. With our structure, which is already in the parish and we want to roll them out, those are the community extension ones, we extend these services beyond just what PDM is doing in production. Because we know they're doing production, but health is wealth, more compared to just the wealth that you are being given. Honorable Minister, this house is full of ideas which we want to tap in. We will take these 5 days to tap in those ideas, but also given that you are here to give us the directions, the guidance, we want to pick it up and run with it. So that in the next few years, come 2020, come 2030, we can also speak to the targets of universal health coverage. Thank you very much, and may I take this opportunity to welcome my director of public health to come and welcome you or give you some words of wisdom and greetings before you can invite the Honorable Minister to speak to you. Thank you very much.
Honorable Minister, our distinguished guests in the community space, good morning. Honorable Minister, I want to start by telling you that I am asking for a selfie. Once that's done, then everybody knows we are friends. I'm going to speak later because I'm sure all these people want to listen to you. But they are also happy because last evening we were having self-care. I saw them also enjoying this community space. I'll give you a report on that activity. But we want to take this opportunity just to say hello, then you sit, and then let the people continue. I'll then invite the master programs, the director of programs today, to continue with the programs so that we can have good time. Will you clap for me?
So, Director, I continue. You have given me the powers. Very good. I use them very well. I'm happy that you have given me the powers. I've got them from the director. And now, audience, you have now known that I am in charge of this. So, with the powers that have been given, we have so many responses in communities. have mpox, COVID-19, but we also have HIV response. And CDC is very pivotal in activities at community level, even at regional level, through regional referral hospitals. So we have a presentation by one of our doctors from CDC, Dr. Teresa. I hope you are ready with your presentation. But as you are coming, because the presentation is going to be Uganda HIV response sustainability. Dr. Teresa is from CDC. But for us in Kaperebel, we had a question as you are coming. Hello, Edward. Can I bring out about sickle cell issues and surging cases before the Honorable Minister in our district? Okay, you Harold, let us first listen to CDC. Harold, with that question, and also tell you about that village where we have so many sickle cell patients. So, Dr. Teresa, you are welcome. Can we have it uploaded? Please.
Our guest of honor, the Honorable Minister of Health, colleagues from government, Minister of Health in particular, but also the nine ministries, colleagues from the district, local governments, regional referral hospitals, civil society, academia, ladies and gentlemen. This presentation I'm making is not a CDC presentation. It was a presentation that was supposed to be delivered by Uganda AIDS Commission and the UNAIDS. I'm standing in for that team because they are not able to be here. But CDC and indeed USD is part of the core team looking at HIV response sustainability. And I will take the next few minutes. 15 minutes. So I will take the next few minutes to highlight some of the work that is happening behind the scenes, working with the different stakeholders to try to develop a roadmap for HIV sustainability. Is somebody helping? Okay, so I will not spend a lot of time on these slides. These are slides that we have basically seen. They are slides that help to project what the epidemic will look like if we are able to achieve our 2030 targets, and what the epidemic curve will look like if we basically don't. The message here is that we need to strive to achieve our 2030 goals so that the epidemic curve increases. So as you can see from the graph on the right, how the new infections will basically decrease if we meet our targets. That slide also speaks to what will happen and how the response will look like if we achieve our targets, if we make our SDG targets, and what will happen if we continue with the status quo. You can see the numbers. If we don't meet, if we continue the status quo, and what happens, and the dip that will we will have if we made our SDG targets. Again, another call for us to take action to achieve our targets. This is again looking at the price of not sustaining the gains. What happens with the infections? I quickly just rush over this. This is looking at the IMF predictions. If we have sustained growth and over the next 5 years at 7%, this places the country in a good situation and to collect substantial tax revenues to increase the capacity to fund the HIV and HIV services moving forward. The slide I was saying. So, the core team has been working behind the scenes to look at our readiness and for our readiness to sustain the HIV response. And an assessment was carried out across those 5 domains, as you can see there. We're looking at political leadership, we're looking at the enabling environment and policies, we're looking at services and solutions, equitable, sustainable and equitable financing and systems. And I will quickly run through the outcomes of those 5 domains. So political leadership, the high-level outcomes that need to be achieved to sustain the response. I think in terms of political leadership at the national level, we are in a good place. The political leadership and the political will is very good at the national level. Variations as we move lower to the district and lower levels, districts, sub-counties, a lot of work needs to be done at that level. But also when we look at the enabling environment, it is important to note that political leadership is needed across all government to support increased domestic funding for HIV, to support the comprehensive package of services for HIV prevention, for an enabling environment, but also supporting more effective coordination and meaningful involvement of the CSOs and the community-led organizations. So political will is very important. Under the domain of enabling policies, Uganda will need action to build on the previous efforts to create an enabling legal and policy environment. High-level advocacy will be needed to review laws. Advocacy at all levels will be required to address the social cultural norms, support for girls and boys, education. We also need more effort to support out-of-school girls and boys under the existing social development schemes like the PDA. The third domain that was looked at is sustainable and equitable, sustainable and equitable financing. Uganda will need to find the fiscal space to accommodate increased spending for HIV and HIV, spending on health and HIV as an investment tool. There's need for mobilization of more domestic revenue through various sources, looking at the blended financing, debt to health, swaps, bonds, earmarking funds from mineral and oil exploration and so on, and increased allocation to health. Recommend an annual increment of 1% of the domestic budget as we work towards the 15% contribution to health. Uganda's HIV response will continue to need extra funding, and government should start negotiations with external partners to maintain fund levels for the medium term. The next area that was looked at was HIV prevention and treatment services and solutions. To sustain the HIV response, Uganda will need to gradually transition the leadership of the HIV prevention and treatment services to public institutions and civil society. IPs will need to strengthen the capacity of the local entities. They have been doing this, but they need to continue and strengthen this for the public institutions, local governments, and CSOs to provide this leadership. All HIV services should be integrated into the primary health care and increasingly provided at the community level. However, investment in capacity building for service integration of the community level structures will be necessary. Achieving and maintaining high coverage of HIV prevention care and treatment services will be needed, but also looking at OVC and nutritional support for HIV mainstream into the social protection services by 2030. Under systems, the assessment noted that as we transition services to local structures and HIV integrated services, and HIV is integrated into the primary care, strengthening the systems by themselves will have vulnerabilities, and we need to look at the vulnerabilities. Financial systems will need to be strengthened through implementation of the health financing strategy, implementation of social accountability systems at all levels, and enhancing capacity for financial management at all levels, and instituting virtual pooling systems for HIV resources. Government will need to take a lead on negotiation for virtual pooling of resources with the development partners and put in place the systems to do so. The Uganda Lab Services, as an example, was the Ministry of Health leadership has been strengthened by HIV through the HIV program, and this strength was given during the recent epidemics, and we need to address the current vulnerabilities. More efficient funding and resource mobilization will be needed to increase the human resource capacity, expand the electronic lab management information systems, and EMRs within the facilities nationally. And supply chain. To sustain the HIV response, there is need to build on the recent achievements, including the strengthening and harmonization of warehousing and distribution of the medical and pharmaceutical supplies. We need to implement a 10-year supply chain roadmap. Efforts should include negotiations for regional market for locally manufactured ARVs and other commodities to lower at lower unit costs. Efforts for stabilizing availability of commodities in facilities, electronic logistics information systems, and reducing wastage through pilferage and expiries will also need to be addressed. Negotiations around a single buyer for commodities among the partners may increase efficiency and savings in the supply chain. Under health technologies, the high-level outputs evolve around increasing readiness for the rollout of new cost-effective technologies through expedited evaluation and licensing of new long-acting ARVs, POCs, testing technologies, IT systems, and appliances. Under strategic information, strategic information, strengthening SI will be crucial for a sustained HIV response. Strengthening and harmonization of the electronic information systems at all levels will be crucial. Supporting interoperability, centralized databases with appropriate information exchange between systems, data security that ensures privacy at individual data, use of unique identifier systems, and finally, integrating surveillance systems for HIV the STIs, viral hepatitis, and other epidemic-prone diseases should constitute areas of focus for sustainability of the HIV response. But also in this area, strengthening the HR capacity facilities is crucial, as well as more efficient human resource management systems to be achieved to support sustainability of the response. Under delivery systems, to sustain the HIV response, we propose that delivery systems for health services be integrated and people-centered through the scale-up of differentiated service delivery. There should be increased delivery of services through community and private sector platforms, through a private public partnership backed by functional nationwide quality assurance systems. Sustainability of the HIV response also requires a shift from the vertical service delivery to integrated services. HIV services should be integrated into primary health care, and HIV services should also be integrated into the social protection schemes. We have identified 5 high-level objectives that should be achieved under this area to support sustainability of the HIV response. Community systems. For sustainability of the HIV response, HIV services will increasingly be provided and supported at community level. Community level structures will need to achieve improved governance capacity, as well as human resource, strengthen the human resource and the information systems at the community. The social contracting of community-led organizations, CSOs, CBOs, will also be crucial as we move towards strengthening the community systems. The areas of focus, as I come to the end, I will quickly run through one of the slides here. So the key issues that the steering committee will be focusing on is political leadership, looking at enhancing the political leadership across all government, ensuring sustainability of the political leadership of the HIV response, and all political interventions and the population. And we talked about the enabling laws. The focus will continue to be restrictive legislation and political and the policies, looking at CBOs and SOs, how they operate and how they can seek funding freely, and then looking at contracting and domestic funding for those SOs and CBOs to provide services. We'll also be looking at service solutions, strengthening the response coordination, comprehensively coordinate externally supported initiatives, looking at the district AIDS committees and seeing how these can be transitioned into the district technical planning committees at district level, transitioning oversight and implementation of the HIV services from our implementing partners to local entities, and looking at the local structures replacing the IPs in the long run. And we talked about increased domestic revenue, talked about high-level advocacy for increased allocation for health, and we are looking at negotiation with partners to pool resources virtually. And then looking at the systems, investment in systems strengthened to allow for service integration, building strong community systems to address the common causes of morbidity and mortality, and increasing the workfield to allow for additional recruitment to fill the vacant positions. We have developed detailed pathways for change for each of the domains. However, in this presentation, we are just highlighting the 4 cross-cutting aspects the high-level advocacy and engagement. The country needs to invest additional resources in different components of the health system. Successful and effective the implementation of the different strategies will require enhanced governance with improved coordination and resource pooling. And then lastly, all these initiatives should focus on utilizing approaches that will maximize the resources invested. That is looking at what the next steps will look like, looking at the feedback from the high-level outputs and the all stakeholder input into the high-level outputs, looking at prioritization of the how to prioritize, because the high-level outputs are many, but how do we work on prioritization, and then developing the roadmap which includes all ministries, departments and agencies, but also the development partners, civil society, and all stakeholders, and then the policy dialogue to have this implemented and completed. I think that was the last slide for our presentation. This retreat is critical because a lot of the sustainability that we are talking about of the HIV response is hinged at district, the implementation level, and then the community level. How do we work towards strengthening the community level? A lot of work is going on within the health development partners and stakeholders to see how do we work towards strengthening the community health extension workers and the village health committees, working with the Ministry of Health to come up with the roadmaps of that training and transition of the partner-supported human resources. So a lot of work is going on. Thank you very much for listening to me.
Thank you very much, Dr. Belisari. Give him However, I have some questions that I will bring here. One, I'm not seeing how you are aligned to our national community strategy. I will ask when you are here. Yes, but I've not seen the roadmap of how it is aligned to the national community strategy moving forward. Thank you very much. I also have to give you a heads up. We shall have a session chaired by the Commissioner, Dr. Mograhi, where we shall have the referral hospital directors, heads of community departments. We will come here and we shall do the mapping and zoning of partners. That will be after lunch, not now. Then secondly, we shall have sessions, the ones who are presented here, and the audience will ask questions. Honorable Minister will sit there. And when you are asking the question, you will say, for example, I'm asking anyone, district, category district, organization, disability initiatives, area of coverage, or a village. What is your target? One household. So if your target is 16 districts, you say 16 districts. If your target is one sub-county, you say one sub-county. If your interpretation is like one household, you say one household. But that will also happen. But before we do all that, I allow me to appoint the next presenter. We are aligning community health priorities to existing resources. What opportunities are available for addressing the community health gaps? Dr. Kam, allow me to welcome you to the podium. I hope your presentation is ready. And I request the IT to present it. Dr. Kama? Yes. someone is, the minister must know you to make sure you pronounce your name very well, as saying this in what? District Academy District. Village of Ogoy. NGO, disability initiatives. Area of coverage, one household. Dr. Kama after Dr. Kama presents, all the presenters will come here and then we shall ask questions.
Thank you. Honorable Minister, heads of departments, mine will be very brief. The recap basically of our financing frameworks and how this thing can align to them. With the, as far as community health is concerned, by definition, community health generally refers to the study, protecting, or improving health within a community. And by within a community, we tend to imply that the community must have shared characteristics. If it's just a group of people who don't share characteristics, then we refer to it as population health. In Uganda generally, because of our service implementation is integrated, it is difficult to say this is a clear boundary. Community health begins here and ends there. And we usually take it to be synonymous with preventive care. Operationally, it encompasses everything that is under Cluster 1 of our Uganda National Essential Services Package, that is health promotion, risk prevention, and community health initiatives. With regard to the resources available, we get a comprehensive picture of the resources available when we look at our national health accounts. The most recent being for financial year 2020-2021. The others are still being compiled. In this national health accounts, we found that we are spending 8.4 trillion in health, of which travelers per capita expenditure of about 209,421 shillings. With regard to the financing sources, as we pointed out the other day, we find that almost half of the sources, 50%, are from partners. Of the 8.4 trillion, about 4.2 trillion is from partners and is managed by partners. Then 28% of the available sources from households and is managed by households. And government in that financial year managed 21.7% of the resources. So it's important as we try to align, first and foremost, to be aware of where the resources we are being managed. The private corporations are making a very minimum contribution, which is 5% of that comes out of households. And there is an even split of where resources are managed. Half of the money is managed by the central government and half of the money is managed by the local government. Though the money managed by the central government usually is quite often used for interventions at local government level, which which are the providers that are managing our resources. We see hospitals in about 40%, then the health centers or ambulatory facilities. We can see that with 12.8%, and then the providers of preventive care and non-facility, these are usually the preventive partners and the NGOs are managing about 26% of the resources. In terms of the functions, we can see that curative care is still taking up 54%, while preventive care takes up 37%. Of course, it is important here to note that the 54% that is taken up by curative care is still grossly inadequate. And the question should be that we shift resources from curative care to preventive care. The issue should be that we provide more resources for prevention. So, in terms of opportunities, what we have found to be extremely important is to align our financing in the public financing, because this increases efficiency and sustainability. And if you are to align to the public financing, then you have to be cognizant of the planning and budgeting cycles. We get the planning call circular from the National Planning Authority, as well as the budget call circular from the Ministry of Finance. And if you are aligned to the public financing, then you have to take cognizance of these documents. And one of the key issues that we are raising is, as you saw, that most money is carried by the partners being able to respond to our budget cycle in the way of providing the indicative planning figures on time. The other key issue that we have to take note of is that we are operating in an environment of decentralization, and the mode of decentralization is devolution, where decisions are made at the lowest possible level. And you have guided them that those levels should set priorities using the bottlenecks analysis. We have produced guidelines to guide on how they handle the bottlenecks analysis to come up with these priorities. What is really encouraging is that whenever they do bottlenecks analysis, the interventions they come up with that will improve their performance are usually community interventions. And this, we think, is the best way that you will be able to come up with the high impact interventions as priorities. Also, we have mainstream output of health-based financing. This is going to increase the quality of the services to improve when we do this, as well as equity, in that the resources go to where more people seek services. Of course, the issue here that we have had with community is the failure to identify verifiable indicators for community health that are used and are incorporated in the results-based financing mechanism. So if this should come out as a key issue to address, in that we need to have verifiable outputs. How do we verify the outputs of our health inspectors, health assistants, nutritionists, so that we can embed them in the results-based financing framework? Of course, all this will also only be effective if there is routine monitoring and tracking of expenditure. Once you decentralize, then you have to monitor and you have to track how the resources are spent. This is an overview of the government's planning framework. We are working towards the Vision 2040. And so we develop 5-year plans to our elements is there, and we refer to these as national development plans. The national development plans are basically like a consolidation of program implementation action plans. And we follow under the Human Capital Development Program. So the Human Capital Development Program prepares the peer as do other programs. And when these peers are consolidated, we come up with a national development plan. Now, following on from the development of the peer, I think the one for NDP4 has been finalized. This was finalized earlier this month. Every vote is expected to come up with a strategic plan. We have a guidance from the National Planning Authority that each vote should have a strategic plan. That's why we are always trying to enforce it. So the Ministry of Health, for example, will come up with its own Ministry of Health strategic plan. So should the others, all other votes. The Environmental Transition Service will come up with its own strategic plan. Mulago with its own, and each individual government with its own strategic plan. And then from the strategic plans, annual plans are prepared. What is key here is that while the annual plans should be comprehensive, and the summary is included in the PBS, the program-based budgeting system, which is used for purposes of approval. Approval of the work plan. The challenge we have had is that quite a number of people believe that once you have the PBS, you have the work plan. But the PBS is a summary. And normally when people come and say that the work plan is in the PBS, we say, can you please print and you have a look? And when they look, they see that the summary is not very informative. So as the communities need to be cognizant of these facts and ensure that we actively participate in the development of these strategic documents. The tendency has been to compartmentalize. Everybody focuses on their strategic document and they ignore the strategic documents that are for the entire unit. But the financing is done to those strategic documents. So we have, as I said, we have completed the development of the peer, and we did put clear outcomes, intermediate outcomes, and strategic interventions for community health. We provided strategic outputs for community health, and we attempted to make as clear as possible the indicators and the activities. The next stage is we are supposed to develop strategic plans, and all votes have been given a deadline of 31st January to come up with a strategic plan. So what is important therefore is that our national community strategy should inform the strategic plans of all the votes, not only of Ministry of Health, but also of Moroto Hospital, of Marara Hospital, of Arua Hospital, and of National Medical Service. Then the strategic plans are also expected to carry pipeline projects. We are supposed to have pipeline projects in the strategic plans, in the strategic plans. I think at the Ministry of Health we have a disability inclusion project that is currently being considered. The only other vote that came up with the project for communities, I think, was the Guardians Commission. they came up with the HIV/AIDS Museum. So all boards are encouraged to come up with these projects. There's a development committee has issued guidelines, and the project has to be proposed in line with those respective guidelines. Then after that, we have the comprehensive work plans, and I have said, it is the summary that inputs the input in the PBS. If you start by inputting into the PBS, then you are preparing the summary of the document that doesn't exist. And it poses the challenges that usually people face. Now, as you have said, most of the functions were developed to lower levels, and the evolution to lower levels is going to increase with time, because that's what our constitution provides for. So we do set a guideline to guide, and this is called the SSR program budget implementation guidelines. We need to take keen interest in this guideline and ensure that what we have, we want the communities, the implementers and the communities to do, is embedded in this guideline. If we have a comprehensive strategy, but the comprehensive strategy is not translated into the grant guideline, then we get challenges. Because the tendency is for the lower levels to say these resources are covered by the grant guideline full stop. So we need to take keen interest in the preparation of these grant guidelines and what is embedded. Of course, we have a standing requirement that 30% of the resources after taking off cost-cutting costs should be reserved for health promotion, education and disease prevention. But the implementation is still being hampered. The enforcement of this is being hampered by the fact that we still need to clarify the definitions of our interventions in practical terms, in a language that the health assistant will understand, so that they can easily justify what the money is being spent on. And as we pointed out the other day, one of the greatest challenges is the absence of the registers for the activities that committed. We have registers for the informal health care workers, we have registers for PhDs, we have registers for Jews, but we forgot to put in place registers for health inspectors, registers for health assistants, registers for nutrition staff. And this makes the implementation of this requirement quite a challenge. Thank you very much.
Thank you very much, Presenter. Can you give him another clap? So it's going to be now a Q&A session. And I'm going to tell Mr. Kaba to move the sentence. Then I will also request Rogers, you occupy the second seat. Yes, Civil Society Plan for Integrated Community Research. The second, yes, because the CSOs are not following you. Never listen, never follow that thing. Yes. Then we have the one who, Dr. Niels. Yes. Alignment towards the National Community Strategy. Yes, can you sit there with us? So, Commissioner, are you the chair for this session or are you chair? Are you chair? Are you chair? So when I hear, I sit here. Very good. So I'm going to change my seat. Instead of standing, I'm going to sit. I think I sit in the middle. Very, very good. Gender balance?
Gender balance.
Okay, now I take this opportunity to chair this session. I'm no longer master of ceremony, but the chair of this panel. When you put up your hand, I ask the ushers, move with your microphones. Okay, you put up your hand, you tell us where you come from, your name. You tell us the question is addressed to, and then I will pick on you. So when I take a decision that I'm picking on you, you speak. If I don't pick you, please don't speak. The first question goes to the, touch their hands. To the right, Kasim.
Thank you very much, Chair. I'm Agoba Kasim, working in America. I'm a behavior scientist. To Dr. Teresa, thank you so much for the presentation. I was so much interested in talking about human resource. You focus on private health training institutions. Yes, we know government has few, only 20 health training institutions, more plus some, maybe about 8 universities, but the population is very, very big, very significant. And we have an upside of HIV misbehaviors in health training institutions and other tertiary training institutions. Yet, Ministry of Education seems not to have a clear intervention plan. How can the Ministry of Health, its commission, come in to support intervention towards HIV? Thank you so much.
Very good, you know that. Yes, we have another hand. So we shall take 7 questions, then the discussion.
Thanks so much. My name is Mabeli Musa, for sales officer Masaka State, but I'm the principal officer in environmental health myself. I have 3 questions. One to the Carl.
To Carl?
Yes.
Yes, Carl Kosotia.
Yes, Carl Kosotia.
Yes.
I thank him for his presentation, but over years, the Ministry of Health has designed programs that favor the rural approach. When it comes to urban, things are a bit different. And in our structure, there are some steps that we miss. Like, for example, at the state, we don't have a sub-county, but then we have a specific field. There is an organization called the Child Restoration Center. I think we have them in Kampala, we have Mali, we have Masaka, we have Lida, and so on. But now for them, for these programs, the target is household for our intervention. But for them, it is not the household, it is now the organization. In the household, they come after they have rehabilitated this person, now take back and hand off. And our services are linked to them. I don't know whether in your plan you have them and they be recruited and so on. Thank you. Then, the second question is on the HIV, doctor. You recommend 1% for our budgets at local government. But now my question is, where specifically? Is it on the health component or the entire, for example, the state grants, so it will be the 1%? It's not clear, and so on. At the end of the day, there's the way things are not moving right. My third question is on the last presentation. Actually, it has been very good. My appeal is that when it comes to, I think it is going to be looked into this code of the type of accounts.
So you realize at times there is a way that also affect us. Maybe as we go on, we are going to identify where we can allocate specifically. Because I remember one time we put in travel inland, and His Excellency said all money which is travel, and yet the way the extension worker, the work is done, basically it is travel inland. So when it is, the finances a bit affected, they say maybe that the other side. I don't know how we can do it.
So Dr. Kamba will respond to that. In the middle here. Yes, there's a hand here.
Thank you, Chair. My name is Hamza Dankaini. I am the team leader and the Secretariat for Malaria and Childhood Illness NGO Network Secretariat. Chair, first of all, I would like to thank the Minister of Health for taking on the civil society as key stakeholders in this, but also our partners. I would like to allude to the discussion that my colleague from the civil society was meant to respond to. Those some questions remained unattended to. And it's the issue of the networks. If you recall, initially we had 4 major networks in this country. It was the one for malaria that Timasis was coordinating and also representing communities affected by malaria on the Global Fund CCM. We also had UNASO, the Uganda network of 8 service organizations for the non-government organizations. Then the PLHIV network, and then the Uganda Stop TB. But as you recall, the growing needs in the health sector with the population as of now, these networks have given birth to different networks. And I think that's where we are having issues, where today there is one, tomorrow there is another, and I think we are failing to have a harmonized way of bringing ourselves together. Because the other malaria docket would want to have our colleagues on board, but still they would want also to have integration, the other side of HIV, TB, and then the other disease components.
Very good. You respond to that? You had another question?
Yes, and the last one. The man of God from Luero, the age of Luero, yes, mentioned about an issue where it is easy to squeeze water. I mean, a stone, a water out of stone, but sharing advantages. I think this issue goes back to our mentors, our fathers, our supervisors in the local governments. We as CSOs, we are like children who have innovations, because our role is to innovate interventions to complement on what they are doing, and their role is to ensure greater and meaningful engagement of us, including the supervision. How then do we have budgets that cannot be tapped into? Yet when we meet different engagements, this is part of what they're supposed to do.
Okay, thank you.
Thank you.
Yes, that's a very good question. Yes, I have a hand there in the middle. Shall I take 2 more questions after that?
Thank you. My name is Stanley. I'm for 7 children. 2 questions. One for the society.
You are from 7 children?
Yes. So, one for the society. How old is the NGO forum that has put us together for a long time? But also, we know that we have the CSO platform. How is the condition? the CBO coalition that we put in space. The use of the finance, the health, Minister of Health, I forget his name.
Yes, Dr. Kamba.
Dr. Kamba, yes. We are liberating, we know that the other pockets contributes about 43% as you mentioned. How do we make the health insurance? How far is it in terms of providing for monthly financing for health? But also, what innovative financing options do you have now that we know that almost 40% of our funding is external? And I think what many of us are praying, for example, to get the leadership, so we're able to get more funds. So how is this option going to move? Thank you so much.
Thank you. How do we live when we have finance? So I think we shall take one more question from the left. Yes.
Thank you, Chair. My name is Gerald Okero from USAID Ella Ventures. We are supporting health systems, focusing on rehabilitation at the national level, regional level, and learning from a few districts in Eastern and Northern Uganda. My question goes to Dr. Kamba. Thank you for highlighting the financial status in regards to different aspects of the health system and services. My concern is on rehabilitation. We know that as of 2021, 7.5 million Ugandans experienced a health condition that required rehabilitation. And we know that rehabilitation is not really for persons with disabilities alone, but for everyone. And I want to assure the congregation here that among us here, 1 out of 5 of us here has a condition that requires rehabilitation. For example, back pain alone affects 1.9 million Ugandans as of 2021. When we look at our budget, presented by Dr. Kamba, rehabilitation is allocated 0.1% only. And yet, we know that the need for rehabilitation is increasing as a result of aging. Our health indicators are improving, and so many of us are living longer and require rehabilitation services, including aging. We know that we have LCDs increasing in our country, and many of them will lead to disabilities or limitations. We also know that disasters are increasing every year and there, and of course the accidents when we talk about the parabolas and road traffic accidents happening in the country. So what is the Minister of Health thinking about increasing this budget? If you look at 0.1 really to meet the population need, I think this is really too little. Thank you.
Thank you very much. The more we age, the more we move towards rehabilitation. Dr. Flavia, you're the last. Dr. Flavia. And someone bring a microphone here.
Thank you so much, representatives. My question goes to Paul. I know that maybe there are two sets of CSOs, the ones that are like the government watchdog, the ones that do community-led monitoring, and the ones that actually deliver services and complement district efforts. How do you, and I've seen that there's so many umbrella bodies, UNASO, MASIS, people living with HIV, AIDS, civil society organization, Uganda Stop TB, NGO forums, CSO platform, CBO, coalition, there's so much fragmentation. What do you see as a future of CSO coordination? How do you want to be supported to deliver better, given these two big groups of CSOs, the ones that do community-led monitoring to monitor government programs, and the ones that actually deliver services? And there might be an intersection of those that do both. How do you want to be supported so that you're not so fragmented and you don't duplicate efforts everywhere you go?
Thank you very much. Let us first answer those round of questions. I will start with Dr. Kamba. You a lot of the questions. So over to you, Dr. Kamba.
Yeah, thank you very much. I'll start with the issue of rehabilitation and the 0.1%. The 0.1% was the expenditure. As I pointed out, we ran an integrated budget, so we allocated budget to the cost centers, these are the grassroots implementers. And then we are tracking to see what they spend their money on. But one of the things that happens is that in their implementation, the curative aspects, for example, the NCDs, are captured under the curative component. However, we have started on measures like I pointed out. We are writing project proposals that will provide specific funding for rehabilitation. On the issue of how do we interpret the CS cost budgets, we already have a framework in the PBS that captures the budget of CSOs that is managed by the CSOs themselves. They are, for example, participating in immunizations using their own money. We still have, we can capture that money in our PBS and we indicate that it will be managed by the CSOs, but we allocate the activities the money will be spent on. The aim here is to avoid duplication. On the issue of travel inland, it is true, it's a policy of government to limit the amount of money spent on travel inland. And fortunately, your budgets are protected as buffer funds, so if there are any challenges along during implementation, you will not be affected, but you are still strongly encouraged to look at the other needs, take a comprehensive picture of the needs, and we think that if the travel inland is planned for at its lowest feasible level, it will not become the main item in our budget. We don't want a situation where the largest item in our budget is travel inland. That will be contrary to government policy. Then how do we leverage on the out-of-pocket? Yes, the out-of-pocket is quite high. And currently in the country we have what we call health cooperatives. Our laws provide for health cooperatives, which can provide insurance services. So we are looking into how best to operationalize these health cooperatives that are provided for by the Cooperative Societies Act. As for the health insurance, the social health insurance, we've made a submission to cabinet and the sub-cabinet to decide when it will legislate to provide us the necessary legislation to undertake. So we are, in the time being, we are going to focus more on how to operationalize the health cooperatives that already have a legal framework in the form of the Cooperative Societies Act. Thank you.
Thank you very much, Dr. Kamba. To the left, how do have you aligned to the National Community Strategy in the HIV response? And how are you integrating the parish development model, reaching the household under the social services pillar? Dr. James.
Thank you very much, Chair. The concern is well noted. Like I mentioned at the beginning, there were a number of outputs or outcomes, and this was summarized into the high-level outcomes that I have presented. And I've taken note that as the lens moves higher and higher, a bit some of the details can actually be lost. But
a lot of what we've discussed and what has been matrixed across the 5 domains we've been discussing is speaking to the strategic interventions within the National Public Health Strategy. Right from looking at the coverage of the services at the community level, a lot of the community interventions are mentioned within the high-level outputs, where we are looking at differentiation at the community level and ensuring that services reach the household. We talked about the community health workforce, which is another intervention, and as we look at the health workforce in general, the community health workforce is key in there, and we talked about the alignment to the Qs and the VHTs, and right now there's an ongoing discussions about how the HDPs and other stakeholders under the leadership of the ministry can actually scale up the Qs. Supply chain, we did talk about it, and again, this was more broad, looking at the 10-year supply chain roadmap, but under that, surely then they need to have the commodities at household level, how they are quantified, the delivery systems, that is embedded. So I have taken note of the concern that the interventions within the community healthcare strategy as metrics across the different domains, but we will look at the presentation to make sure that it becomes more succinct. Another question I was talking about, I think, the HRH and the training institutions and the training curriculum. Yes, as we talk HRH, they need to talk about how do we work with the training institutions to ensure that a lot of the skills that the health workers are given from in-service training can be provided free service. That is going on, and many partners are supporting the health training institutions to help review the training curricula to ensure that that is included. Right now, the challenge has shifted from the lack of the health workers out there to specifically targeting specific skills that we basically need as we move forward. In terms of the general HR, that we have enough numbers out there, but the target, when you look at the suggestions, is looking at what are the specific cadres and the skills that we need to move forward, and how can we work with the training institutions about that. And this is linked to the labor market analysis that is periodically done to look at who is available, what is missing, and how can we work towards having that covered. And lastly, the means, the 1%, I think Dr. Kamba was better placed to talk about it. We've been talking about 1% as part of the resource mobilization strategies for HIV at the district level, looking at all the funding to the district. But I think Dr. Kamba will be making a comment on that. I think the bigger question we have is, away from the budgeting for the 1%, what is the utilization like? The local governments go forward to actually utilize this money beyond just having it in the budget. I think those were...
So, Dr. Kamba, do you want to talk about the 1%?
Thank you. All votes have been asked to use 1% of their budget for mainstreaming HIV/AIDS. Now, at local government level, you calculate 1% of the budget, but that 1% is only allocated from the unconditional grant. It is restricted. Expenditure on that 1% is restricted to the unconditional grant, non-wage of the local government.
So, as a capacity, you have taken note, we have responded very well. man of God, you Carl Consortium, you are living out so many of us, so many cities. What is the criteria you are using to map us?
Thank you, Edward. If I speak, I cannot start answering the question if I organize the presence of our beloved minister. There's something about her with what I'm going to talk about. Honorable Minister of Affairs, Honorable Jen Cheng, she spearheaded the National Community Strategy. And when I came back, I used to be all over whenever they ask me, I find like I tell lies. In Uganda, yeah, it's okay. When I came on the ground, I found there was going to be issues with women body. So I found Honorable Jen was pushing the National Community Strategy. And I remember one meeting that I whispered to her about how we are embracing it. To begin, I have a bit of many questions. Thank you, Honorable Minister, for that. The first question is about South Central region. Masaka, talking about such a network that you mentioned about 4 districts. I need to highlight this audience that when we were starting the Cargo Consortium, we looked at the means progress. We looked at the community. We looked at how does the minister in Kampala be able to get information at the household level. So we started the CAL, actually when we were beginning, we started the CAL network, then as I told you, we had donor consultations and the expert opinion, food orders. No, networks are now defined to people come up and say we are network. The kid was saying that the CBOs were focused on household. So we said we're going to be a consortium. What we avoided was opening branches with Barara, with Pad, Solonti, opening branches of Cargo Consortium. We decided to promote community ownership, making the communities the custodian. We have here about 12 people in Uju and Barara here. The doctor can also testify, can I say. So we decided to use the district level governments to identify 10 CBOs by district. That's what we have started with. How we did it, in our mapping and profiling, we made sure the CBO, every CBO would bring, at first it was so stringent that we would expect every CBO to bring a CAO recommendation, a CBO recommendation, and a certificate of registration. Along the way, we realized that the CBOs, the CBOs under the CAO, so we don't need to really expect a CAO recommendation when the CBO is given. But most of the CBOs that first came on board, they all have CAO recommendations. So that was the issue of legality to avoid CBOs focusing on one household. And we did that successfully with God's grace. We started with 40 districts, 8 here now covering Control. So South Central region. Amazingly, we found out that the National Community Strategy has an opportunity that it talks about CBOs. These CBOs you see, where it was amazing and shocking that all CBOs, not all, were able to do online or we assess them online or online attended webinars, capacity building online. That's how our community has moved on. So we reach it. So South Central region, we are already having CPA for the Massacre South Central region. If you have any questions, CPA can handle, because we believe we are forming district car network. After forming the district car network that are all over now, and we developed terms of reference by encouraging the district car networks to nominate in each region and organize this thing. Themselves, they think can really plan their affair. And as I talk, that's the process of being, and it has been amazing. They have chosen, like they said, one CPA for vision ABC. So we are going to empower the regional car networks to go and empower the district car networks. Why are we doing this? We are streamlining to make sure with the car consortium, when the big surveys want something, the car consortium will deliver it from the household voice level. We are doing this to make sure making communities the custodian, the CPOs, the reaching, and our tagline is championing integrated service delivery. In there, we have also put in live group programs and going into live group programs. We have a bank, like you
have a bank.
We have a bank. We have in an MOU. We went to an MOU with a bank to provide financial interest at all our district car network, the CPOs. So South Central go to CPA. The second question was about the network also. We are also about the network. I think the same answer answers that. So there's malaria. Our difference, we are coordinating consortium. Our networks are district level, CBOs, the household. So we don't have, we are community. If you come to the consortium, national shall talk about household issues and community issues about integrated service delivery. The strategy is there now, tools and BDC, VSTs. Then another one, CSO participation.
You have 30 seconds.
30 seconds, I'm going to use Flavia was saying in brief, as we are anchored in the National Community Health Strategy, which is a structure. So far, the donor I may not mention here, the meetings we have had with donors have told us that IPs, each IP can work with a kind of consortium wherever they are, because we are there. So we are building a structure that is streamlined, anchored in the National Community Health Strategy, and we believe with that can be able to aid and the one man, one budget that the minister is always telling us to do. May I listen carefully to whatever she's talking about those issues, and they have come up with a strategy that we will address them. So, Mr. Fadi, I don't think duplication will come because we are assistants. Very organized.
You have a very good slide, right?
Yes.
Very streamlined.
That any donor will come and support you. If it's going to come and find there is a
yes, we are finding your
support and that's what we're pushing in place.
Okay, thanks. I think last of ceremonies, I hand over the power to you.
Thank you very much. We need to thank all of them. And please walk back to your places. And while you are walking back to your places, we need to give the hand clap to the session. The chair for this time. Our colleague thought was wise that this time around we see the honorable minister to give us a word, but due to public demand, there are groups of people here, they call themselves the local community. And they have expressed that if we allow the honorable minister to speak first, she will not have listened to their voices. They have special voices. Now I'm going to request who these local communities are, whether they are 2 or 3 or 4. By show of hands, can I see those ones who want their voices to be heard? The local community. I can see one there. Please come and take a seat here. Another local community voice is coming from there. Come. This retreat is yours. You are crying that the minister doesn't listen to your voices. She is here. Come, where is another one? Come and take a seat. I have enough seats for all of you. Yes, please, come over. For some of you are not classified as local communities, but you want to speak to the minister. The honorable minister assured me she has all the time today to listen to all of you. Please, the honorable minister. if there is still one space, stand up. Because I still have enough spaces for you. Okay? By the count of 1, 2, 3. Now I don't see anyone else. Dear participants, we don't know what is in the hearts of these people. And because this retreat is theirs, I'm going to give them 5 minutes each for them to speak and what they want to the minister. But also for us to hear, so that we can align ourselves for better service delivery for this time. I will start with the lady, because the lady's delivery decided to sit on the other side. The other gentleman has spoiled now the lady. We will now start with you, then we will flow in this direction. 5 minutes, please. Okay, let's be clear with ourselves. Now, colleagues, we will not have tea break, but there are refreshment points out here. At your convenience, just go systematically out. Serve yourself. If you see it, you can come forward and sit with it here. You are at liberty. Okay? But you don't come to disturb the status. We are going to be sitting in a manner that there are seats which look like seats in the airplane. Stand in the seat there, sit, listen. If you have anything that people do, we have provided for seats out there so that you can help do your things out there without disturbing the status of here, but also by listening and admiring some people and asking questions. Thank you, God. You will clearly tell us who you are by classification, what you represent, and what you want to project here. So that the minister also knows that I was in the battle, and this kind of location, this is what they are showing. This is the only time the minister will remember you. Can we start from there? 5 minutes.
Thank you very much. Ladies and gentlemen, I'm called Geoffrey. I come from Young District, Abensab County. I'm a 20. I'm a community. There are so many activities which we are implementing at the village level. One is ICCM, that is Integrated Community Management on Childhood Illness. We have been trained and we are working. When the household has a child and the child has a fever, they bring the child to the field, as they will say that, test and treat. And this is what we are doing. When we get the child and we find that the child is positive, we give a coagulate according to the age of the child. Remember that we have a chick. So, that's our guy. We don't treat wrongly. This is what we are doing. When the child has pneumonia, we have amoxicillin. All these things we use to guide. See, job again. Help us. How many amoxicillin to give to this child? This is what we are doing at the village. When the child has a danger sign, vomiting, convulsing, the child drinking, we insert record attention accordingly. And we save the life of the children in the village. That's what we are doing. My question to the minister, since we are working as a team, what's the proper budget for the VP? I know that the problem is where we stand. We are working as a team, but when it comes to the term of motivation, there is no motivation. This is essentially speaking. And there is other activities we are doing worse. We are working house for house to sensitize the community that they should also for popular dream. And to be a champion, you must be a VAT who has an ideal home. When I talk of an ideal home, it's a home that has a dream, it's a cover, improved the dream. If the flow is a temporary dream, but the flow should improve. and that's an unforeseen facility. The stove must be there. If there is no stove, ash, we are using this ash. Sometimes there is no stove, we are using ash. The mosquitoes are out. This is what we are doing in the village. You have a dry ash. In a rubbish bin, when we construct a rubbish bin, you construct it square and you divide. You divide. In that rubbish, you divide. One word to big is the when you pick the cassava, the sweet potatoes, the banana, that one can be on the market. What about the tree? We put the aside, then we burn it to save our ground. That's what we are doing in the village.
Point taken. We'll move to the second local community member.
Thank you very much. My name is Lydia Subuga. I'm a sign language interpreter and an expert in disability. I work with the movement of women living with HIV. I'm a woman living with HIV for the last 17 years. And I support the deaf community, people with hearing impairment at Malmö and other facilities. We have a total of about 30 deaf clients, recipients of care that get treatment from Malmö, Uganda. But I also support female sex workers with hearing impairment. Yes, Minister, the rise of women with hearing impairment is on the rise in sex work. And this is due to unemployment and other challenges because we realize that communication barriers, and realize that mostly of these are HIV positive as well. So accessing treatment is also becoming very hard. We appreciate that under the program we have sign language interpreters that have been allocated to referral hospitals, but basically these recipients of care go to private facilities. And the other challenge is the 460 that is allocated to sign language interpreters. Remember, a sign language interpreter who is interpreting science is as much as a science person. So 460, no one, few people are going to apply to work as sign language interpreters in those facilities when they are interpreting science at 460,000. It's really hard. So that's why you realize that most of the deaf clients are also going to facilities that have sign language interpreters. And the RETREAT, because sexual reproductive health services do not treat them because they are not interpreted in many languages, and including theirs. But also, disability has different diversities. Those with visual impairment, those with physical, those with hearing, they have different needs. So realize that we're not reaching every individual, most especially if we have important documents. Why don't we have clips, or why don't we have sign language interpreted into these documents so that at least we can reach as many people as possible? Thank you very much.
We are preserving handcrafts that will come in the glamorous manner later. Let's have the next lady in the green.
I think it is still a morning. My name is Navanda Mariam. I'm a musical worker from the Master County District. I'm supported by the Community Center. I'm a community health worker who does home visits. We visit home by home. I have over 350 households in my community, and I visit there accordingly. Most of the work we do as community health workers, my first colleague talks about it, but I can also add to that. We do health education and promotion. We teach our community members on the health of their bodies. Most of our community members used to do self-medication. We have been fighting that in our health talks and health promotion. We do refer pregnant mothers to health facilities for antenatal care and self-deliveries. We also continue them up for postnatal care, and we can encourage them to take their children for immunization. In our communities, we also do nutritional assessments for children 5 years and below. We use the mock test, go with it for forms where we find children who are young, carry out the nutritional assessments, and we refer those children who need supplements to health facilities for supplements because we don't have us. Then another thing, in our communities, we have been able to embark on malaria prevention by encouraging our community members to sleep under the treated mosquito nets. We encourage them to repair the nets which have holes. We encourage them to clear the bushes around their homes. We've been encouraging our community members to plant mosquito repellent plants around their homes, like rosemary flowers and green grass. That one has been helping also because we use it as a medicine also for putting in our tea, and also we use it to help us with mosquito repellent. But the fact that the Ministry of Health is rolling out the CHIP program, Madam Minister, I urge you to prioritize us the community health workers. We already have the required qualifications, and we have proved our commitment to community health work, even when we are not given anything. Let us not look at our commitment and the dedication which already exists in us. But I also have a question, Madam Minister. Is there any hope for Jews to be added on the pension scheme?
Okay. We have taken note.
Yes, thank you so much, Honorable Minister. I'm so glad I stood up. I'm not local, I'm international. I'm doing local work at home because why? Professionally, I'm a musician. I'm also a creative director. I work with different NGOs and supporting young people, most especially to access justice. With my organization, we started as a community-based organization for artists. I'm Mwaka Benson. Yes, Mwaka Benson from Kivu. But if you want artistic name, it is MC Benny. You can handle me, you'll find me online. My organization, we started it way back in 2010 as artistic movement, community-based organization. We looked at how we can change our community through our art because we were going through a lot of challenges by that time. And we started a movement that is Northern Uganda Hip Hop Culture. And when we started that, I was the chairperson. Why am I saying this? I want to appreciate some of the concepts that the government came up with for the national NGOs to work with the CBOs. I became the director of my organization just 2 years ago after learning the concept that if you want to be an organizational structure, you have to have a director. But before I was operating as a chairperson. And that training came when TASO identified us with the good work that we're doing in the community. What we do with social behavior, change communication. We don't treat, but we give you the medicine through the message that we pass to you. So you will find that sometime translation of all these amazing guidelines and policies that are given, if we don't translate it in the artistic way to the community to consume, it is still a waste of time. Why am I telling you this? When COVID-19 came, all the art department we were the first to be closed and the last to be open. People to go for entertainment. And there was nothing like budget and everything. But the role I played in my community, that I stood out, I don't care if I'm not recognized anywhere, was to stand in the context of the Department of the Risk Communication and Community Engagement. My voice was used for road rage. I was working tirelessly, telling people all the SOPs in order for them to be safe, because we need them as our customers for artists, and we need them to survive, because without them, we shall not progress. Now, what does it bring now to the health concept? I want to let you know, so many amazing international NGOs are here. They come up with a concept to us and tell us that we need community-based organization. Thank Carl today, we interacted yesterday about, but you'll find that you come in, these are the people who interact day to day, and we come with uniqueness of how to approach the community members. I can go to the ghetto youth today from Mali and I be with them the way I am, and they will associate with me. When I go to Lila, I interact around the pipeline where the boys are chewing me and everything. I see a young girl who is even less than 18 years walking among them, and I'll be like, my sister, how can I help you? And I give her the messages which are okay, and those are the ways that we feel we can reach down. But you'll find the design they give us, it is very tactical. Why am I saying this? You come and say you need CBO, but you're assessing them as CSOs or NGOs, level, and you know that they have to implement. And our work is very cheap, by the way. A work of 500,000 for CBO will be accounted for NGO almost like 5 to 6 million. So I would request, my request now here is that number one, let us see on this. How are we going to dwell with the SBC to make sure this amazing community health strategy implemented down there? Let us engage, let us use artistic approach, because they say Africans, our library is in music, our memories are in music, our medicine. Before a doctor, even doctors, yesterday I said to other doctors, I said, I'm a doctor to you because when I sing to you, I will heal you.
Now we shall be moving from the Yemen.
Madam Minister, you're most welcome to this room. I'm called Kasaja Ali, but I work from my district. I'm a PhD, and I work under with World Vision, under the Ministry of Health. Totally, with the PhDs, our challenges almost is one. The first day we raised our challenges as PhDs, but they told us that we need to wait for the honorable doctorate here. Thank you for coming. We are doing a voluntary work. In your constitution, with the volunteers, we are not even supposed to be paid for any single coin. But Madam, we are taking your office, at least we have, for us also a monthly salary, even if it is 1,000 with the PhDs. Because totally we are very, 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 very good when we are doing the work. We are the ones who are doing the work under every line. We are the ones referring mothers to the health facilities. Because those doctors, they are the ones waiting for the mothers. So for them, they just sit and wait for the mothers who are being referred. Then for them, they operate. So, Madam, we are doing a very great work. So for the case of transport refund, this goes to office. Secondly, we as the DSTs, we are underselling the rights of the mothers and even children and fine. We always do home visits. But even these mothers, we always encourage them to deliver from the health facility, not to deliver at the TBAs. But still we always ask for help. How can we help them? Yes, when you are referring me to go for air antenatal to deliver from the health facility, what are you going to give me? Now, we as the DSTs, at least we need to have also our offices. Now we give out the mama kits to them. At least when we see someone coming from the hospital delivery, then we provide a mama kit. Then even others, they will even admire that, oh, it's better to go and deliver from the hospital. Then, we as the DSTs, it's better you provide us with a kit of DSTs, which is having everything. We've been receiving t-shirts, we'll see, but we end up getting one of those. So, Mama, wake up on our issues. For us also, we are together. Lastly, we are trained as the DSTs under nutrition, but as Mayuge, I don't know where your poverty comes from, Mayuge, but you always teach them to feed their children well, but they even ask for us some kind of food which are rich in proteins, the bodybuilding foods, what. So at least you give us some packages of food we can provide it to them. Then that's the issue of transport. As we are doing a voluntary work, but even time comes we get tired of moving up and down. If there is a chance they process us, even if it is a wheelbarrow, we move around and we break that and we do something. Okay. Thank you.
Okay. Finally, next time, our last will be together.
Yeah, thank you very much. Honorable Minister, I last interacted with you when you were the Director General of Health Services. I'm called Wataruga Franklin. By then I was working with BCDS Northern Uganda. After my retirement from public service at the level of Principal Human Resource Officer, I chose to do Executive Master of Business Studies, majoring in Human Resource. I did my practicals from Guru Regional Referral Hospital. I picked interest in the health sector and I've never gone back. Here I'm representing the Executive Secretary of Uganda Orthodox Medical Bureau. I want my colleagues from the medical bureaus to stand up for recognition because we have 4 medical bureaus working closely with our ministry. There's Uganda Catholic Medical Bureau, Uganda Protestant Medical Bureau, and the Uganda Muslim Medical Bureau. As you will appreciate, we are coordinating over about 1,000 health facilities in this country. And we have hundreds of health workers we are supporting. All of us here, maybe with the exception of those ones who are not here, have Christian names. So these facilities are affiliated to our various churches. There are those under the Catholic Church, those under the Protestant Church, those under the Muslim, the mosques, and then those under the Orthodox Church. Now, our entry point here is that we go to facilities which are supported or which are affiliated to these various things. The challenges we've had is that we have budgetary constraints because when government enhances the salary for health workers in public health facilities, our staff expect the same enhancement. Unfortunately, we serve in the disadvantaged areas. Even if there is some user fee, that money is not enough to support the staff. And naturally, government is recruiting from our health facilities. Yes, we have a doctor here today where we are paying 2 million, when you raise to 3 million, 5 million, even if I were the one, I wouldn't stay. And so this is the scenario we have. We have problems of attraction, but we are reaching out to the most disadvantaged. areas where perhaps government is not so decent, I'm sorry to say, it's decent but not so much decent. And then we have, of course, financial constraints for our services, including the infrastructure. But that said, I want to appreciate the Minister of Health because we have been brought on board under the public-private partnership. We are also part of the technical working groups at the ministry. And when we are talking of same plan and a budget, I was just smiling to myself. I think I said it might tap into the ministry budget to help us in many extent services. I want to assure myself with my colleagues from other bureaus, tell you that we are looking forward towards that integrated budget, because our budgetary expenditure, especially on the would-be services, is limited. And the earlier we do that, the better. We are grateful for this invitation, and it's a sign of recognition and confidence in us, the bureaus. Thank you very much.
Thank you. Now, can I request all you to first stand up and stay where you are standing? First stand up. Now, we are going to give them a round of applause as they walk up to us. I am going to do this request to rest because when the photo movements come, you will go and stand somewhere there and take a photo with them. But that will come. Certain voices were coming from the back that I wish these people would also mention this. I wish people, now, you the silent voices, I show you who were you. Wash your hands, you will come and take seats here. The first 6 who come and take seats, the rest will now stay in home. Because after that, we are people who are overbodies and come and us. So if the voices which we were saying we are not spoken properly, we want to amplify, come and take this seats here. Start with seat number 1, seat number 2, seat number 3, number 6. And we will stop there. If the visitors are not come, you cannot go to the center. Okay, now we are using one chair for the agenda. So the rest will now take care. Okay. Now remember, you are going to speak now on behalf of others who are not spoken. They seem to be what you are here from local community and you are not saying, and you want to amplify this. Again, I'm going to give you 5 minutes. After that, I'm going to invite the minister. Come and speak to us, but you also speak to the very many concerns going here. And also the question today are asked for if they are families and they do not answer today, or because they want to clarify the issue. That's how we are going to go. Then after that, we will go for lunch. During lunch hour, we will have close interaction with whoever wants to make up. But we will not allow the minister to because but let's say this time now we're going to start from this side and move in that direction. Tell us who we are. We are typical classification. What is
Thank you very much, Dr. Pinto. My name is Pauline Pinto. I work in the Wellness Community Center and I'm representing the voices from the community. And one of the voices that I'm bringing out here is the community workforce. The community health workers here at the PhDs talked about payment, but I want to justify the reason why they actually have to be incentivized, paid, or motivated. One is that these days the demand for healthcare services has grown in the community. Not only community, even here, we've seen self-care, we've had self-care coming on board. We are talking about NCDs. We have nurses at the hotel. This is because of the high demand of healthcare services. And therefore, these PhDs spend most of the time. We talk about 4 days in the community, or maybe working 6 hours.
but it's beyond that. They are currently working more than 6 hours, they are working 24/7. And that doesn't give them time to actually go out there and do something that can earn them income. These are people who have children, they have husbands, they have dependents, and all these people really looking up to them. So I feel we should be considerate to the community health workforce. As much as we are talking about them being supplied, them being volunteers, them going out into the community, serving the community and all that, we have to also factor in that they have dependents, and these dependents have needs. They have kids who have to go to school, they have girls who need money to buy pads. How are we going to ensure that that is taken care of if we do not facilitate them, if we do not come up with initiatives or ideas to really improve or boost their household income? So those are the community people I'm talking for, and I believe that together, as we sit here, as we go out to our communities, we are going to put this into consideration. They are human beings, just like me and you.
Very good. Next.
Henry, I'm a correspondent. I'm a product of community health. Yes, I'm a product of community health, and I'm a senior PhD. Whereas there is a kid that I am what I am because of community activity. So I really accept all what the duties have said. And I was curious the other time concerned, and somebody said that the duties have not done much. I was really disappointed, yet what they are showing on the screens is majorly done by the DFT. And in my own capacity, I pray for the DFT, that God bless them and they reach the heaven. I want to ask Minister, I'm concerned with the IDC materials, because I work with ministries times, but who is responsible for IDC materials? Because pictures do a lot, they talk a lot, but we are used to the face. I don't know what is happening. I will just want maybe to hear. And what are the plans? The other one is the counseling services. I looked at the list of the employees. We all need counseling, isn't it? We are stressed. Many workers are getting problems mentally. I don't know that you've seen that. And because of the stress and happening to us, but we're not considering counseling services. If you go to facilities, you need counselors. But when you look at the employees, we don't have any plan for the counselors. The other one, maybe the last one, which I wanted is about malaria. Means I'm here to ask, we have a lot of implementing partners in reference of malaria. But malaria is still persisting. You and me know that we are doing a lot, but malaria is still persistent. What are we not doing? Thank you very much.
Okay, thank you for speaking your time. Yes, Sandy, please.
Good afternoon, everyone. I am called Jacinta Nawanga, and I think it would be good for me to greet you because we are in Mbale. I work with a non-government organization here in Mbale, and that is Jenga Community Development Outreach. Our coverage area is up the mountain, where it is really, really hard to reach. We have to hike to go to work. And we do community health as well as menstrual health in those hard to reach spots. My concern is about traditional birth attendants. Now, I know it is probably something we have phased out as a government, but it is actually still existing. When we visit our health facilities up on the mountain, I'll give an example of Wanare Health Center 3. You find there are low numbers in deliveries at the facility. And when you interact with the midwife says the mothers are in the villages, they are delivering in the villages. And when we get to talk to the VHCs, Yes, mothers don't want to come to the facilities because of probably services, the health worker is not there, distance. So she chooses to go to the nearest traditional birth attendant. However, we also know that majority of our deaths are due to these mothers, are due to the TBAs. So what are we going to do for them? Phasing them out seems not to be helping our communities. However, as an organization, we have tried to work with them and we have transformed them into referral attendants. So what do? We talk to the VHCs, to the TPAs, and we do encourage them to deliver their mothers, their so-called mothers, at the health facility under the guidance of a skilled health worker. And over time, we have seen that really yield good results. So I request the minister to think something about that, because spacing them out seems not to be helping. The next concern is about the same how to reach communities, because it's where our passion is. We do have, in Mbale we have a coalition called Mbale Coalition Against Poverty. We call it Mbale Cup. And they have set up, brought for us motorbike ambulances in this community, some of our communities, including in Duda, Manafa, but I'll focus on Mbale. We have a facility, Budwari Health Center, up that mountain. And right now, even if we go with our beautiful land cruisers, I can assure you, we shall not be able to make it there. We shall park it in a center, get a border, or else actually the border may even fail. So we shall have to trek there. But this is a beautiful health center but sometimes we can't get mothers to get help there. In case the facility, the doctor is not there. So what do I request? I would like to request the minister to think about other transport means for these people. We started giving them stretchers, but over time, we also ran out of resources. But if the government takes it up, that these hard to reach communities, the ones where they have to carry mothers who are in labor on chairs.
Okay.
So if we get up, if we do stretchers, I think it would be of good help for these hard to reach communities. Thank you.
Thank you. Next person.
Yeah, good afternoon, colleagues and honorable minister. I bring home greetings from Uganda and also Uganda Muslim Council. We are having our golden celebration on the 12th of December, and you are all kindly invited. Please come for the celebration. Two things I have. These are just merely concerns. One, honorable minister, sorry. I'm Paul Wagago Faisal, a medical laboratory scientist. Just until last month, 2 months ago, I was handpicked to dance at the medical bureau because that position has been done for a long time and the facilities are all there. So I've come on board to support them. Our colleague said we no budgets, but we have to make sure that things move. Okay, two things, honorable minister. And as I said, these are just merely concerns. One, but the other 9 ministries, I think they are failing us. I come from Nakasek, I've been in Nakasek local government. In terms of our services we're offering, we're doing good work. Madam has been there supporting the art clinic, the water and all that. Honorable Minister, the poverty levels are downwashing what we are doing. I would say we are doing good work, we have done curative, preventive, we are washing but later on coming with dust. How? I got to go through our data and I realized that the dropouts, the daily dropout, where people turn up for their clinic days of about 5 to 6. It's such a big number, and when I inquired what was the matter, it was the issue of poverty. So the other day as we're presenting, I'm happy the fourth class come on board and so on. I'm saying, why don't we take this on our matter? This people have really failed us, the other ministries. And since we're the custodians of health,
And health by definition, it's the state of complete. Why don't we complete this? And just not only remaining into curative and preventive. Yes, Honorable Minister, have done very good work. I looked at your policy, the ministerial statement, the policy, minister statement policy. Oh, very beautiful book. Really, I said the Honorable is doing very, very good work. I've never seen such a book, but I walked in the MS's office, I saw that policy statement. He said this is really doing a lot of work. Now, Honorable Minister, that issue wanted us to hold the ball by its own. We are the custodian of health. This one failed us. Let us now that getting money giving to people like the LCs. But we already have the structures. We have this to utilize our structures and support our own people, our own patients. We create groups, we have those groups there, we have some incorporated activities we give to these people. Then the other is, the second concern is about the polythene bags. I remember some years back there was total ban of these polythene bags. Of recent I was in Mainland going to buy a lighter, just a lighter. Don't ask me for what, but it was a lighter. And someone was packaging it in a caviar and a polythene bag. Madam, of recent, the American Doctors Association gave answers to about 52 cancers, and they made a pointed out the plastics. These plastics here, okay, these ones are reusable, they can be some kind of polythene bags. Madam, what's happening? There was a ban, but these things are everywhere, all over the place. They have gone into our soils. People are planting things, we are getting carcinogenic substances from this plastic. Means I don't know who is supposed to be responsible for this, but it's near lack of concern. Lastly, I happened to take some food stuff for my friend in Nairobi. Whenever I go to take food, they make sure they pick all those things out. They say, do not take that thing there. You can't take any content back to their country. I've never been there, but I want to, maybe through your office, give me a 6 day. I got the benchmark, I see what's happening here. This is the same story. This is the same story in here. I'll say this one to you, but otherwise, this nutrient also is by the phone. Once I had the increase, I remember when I joined medical 10 years ago, 15 years ago. Almost 16 years ago. We only used to have one that where the American cancer patients on OPD, where they treat them well, all seated. This was the only one there. Right now, the ones are full everywhere. Cancer is an that no one has mentioned the cancer here. I'm disappointed, but I know the Honorable Minister. Give me that chance. I want to go to Kenya.
Honorable Minister and Director Public. Once again, my name is Gerald Bukero. I work with USAID Learning and Building for Rehabilitation because once again I want to add my voice to rehabilitation. Yesterday we were talking about money economy, but I asked myself, how do we reach money economy when most of your population is not functional? Look at the person with disability who does not have a wheelchair, and you give him a 1 million. What will that person do with that 1 million? He will first buy a wheelchair. And what will happen to the economy? He will not use the money for the economy. So I want to raise a concern, Dr. Kama talked about the budget of rehabilitation. We appreciate that the ministry is actually writing proposals to have a budget for rehabilitation. And we know that in our current health system, rehabilitation services are mainly available in the urban centers, when the urban and the peri-urban, that is the regional, where regional foreign hospitals are located, the national, the private sector hospitals, that's where you can find rehabilitation. When you go to the districts, most of the regional, the general hospitals, we are being recommended to recruit rehabilitation professionals, they are very well there, so they are not rehabilitation services. When you go to health center 4, to health center 3, and the community, you hardly see any rehabilitation services happening at that level. Yet we know that majority of our population, 75% live in the rural settings. And imagine an old person or a grandparent of one of us who gets a stroke and lives in a certain village and requires rehabilitation for a long period of time. But at the community level where that person lives, the rehabilitation services are not there. You have to travel to a private hospital maybe in the city or in the district where that's where you find services. We have tried to work with community health care workers. We have trained a couple of them, the VHTs, the Qs, and they have been very, very active in identifying persons to repair rehabilitation. Children, adults, old people, all of them. When they refer them to health facilities, we have also tried to learn from task sharing, train some of the medical doctors, the clinical officers, and nurses to provide best services. But the demand is high. The LT, when we talk about assistive technology, is actually not there. So most of the people they identify in the community, they come to the health facility, they say we don't have LT. What do we do? So they stop actually responding to this need. So when we talk about the budget for rehabilitation and LT is actually not adequate. And most of the partners who are here, when they are planning and budgeting for health, rehabilitation is actually not part of their priorities. And when I heard the gentleman from the Health Commission talking about 1% for HIV, I'm asking myself, why can't we have 1% for rehabilitation and HIV? Because any person requires rehabilitation. You have a mother coming for ANC, but she has back pain, or she has a problem that requires rehabilitation. You ignore that problem, but you attend ANC. You have a person with HIV, the person comes to give the ARVs, but the person goes to pay, and you leave that person unattended. So when we talk about universal health care coverage, when we talk about holistic approach, the partners who are here, are actually not doing that. We are being selective, and it will be difficult for us actually to realize universal health coverage. We keep talking about this long and behind, but if you're only looking at TB, a person with TB will definitely require rehabilitation. But in your budget for TB, you have not catered for rehabilitation. How do you expect this person, after being bedridden for 1 month or 2 months, get back to normal function? So, Madam Minister, working with the Minister of Health, Division of Disability and Rehabilitation, we have tried to come up with a strategic plan that is waiting approval. We hope that through that strategic plan, we shall be able to streamline provision of services for rehabilitation and AT across the country and all levels of care. So my request here is to put to Madam Minister that if this strategic plan is expedited, so that we have it approved, so that when we are budgeting for 2025, 2026, it's also taken into consideration. Thank you.
Okay, thank you. Last,
thank you, Honorable Minister. Thank you, Minister of Health. I also want to thank Robert Fan and Tasso for streamlining the community to come and participate in such big, very important function. I am coming to give my name. General Tebe says the sun reaches the short person last. And I think the minister also saw my position. I am also the shortest person where the sun reaches last. I am Arichi Tohaseli, working for Fletcher Community Action, Koboko, field based in Yumbe District. And I think Yumbe District is the shortest district to be reached by the sun. I want to request, if you have ever gone to Yumbe, show of hands. Thank you, you reached there. And this gives me a very good platform to put my request. Thank you, Minister and Minister Minister of Health, I have seen very good guidelines from Minister of Health. And that is a guideline which comes with regulation. At first, men were not attending to antenatal, but when regulation came, that if you don't go with your wife for an antenatal, she is not given services quickly. And this gave us, as advocates, we empower the community to also pursue. If you are going to put me on the bed, you also accept to go with me to the health center for services. I think that's why we have male involvement in antenatal. Honorable Minister, one thing for those who have reached human, you have seen in those chairs our young men assemble along the road, waiting for accident to happen such that the victims are extorted to get economic empowerment. And it is a catastrophe. If you have ever gone there, you see chairs along the road, they have made their own chairs to wait for accidents. And when the emergency people were talking, they did not see that. Finally, the last component which I want to put straight to Honorable Minister, why are we looking at Mariuki as substance abuse when water can be substance, food can be substance, anything can be substance? Why don't there be a specific regulation for Mariuki which is eating our young men in northern Uganda? Whenever we advocate, they will say there is no regulation for Mariuki, and our young men are becoming docile. And in every population of 4 to 10 people, 7 must be Mariuki chewers and the opium smokers. But there is no regulation. We don't see a law coming to cover this clearly. Could you address, for the sake of my district, it is an act for me, I call it terrorism, if the government does not see it as a terrorism, because that population is getting derailed. Finally, the PDM empowerment. I think most of us, when I sat down there, they were doctors, permanent secretary. I want to ask, were you, when your mother gave birth to you, were you a doctor that same time when you were out of your mother's womb? And why are you giving money to people you have not empowered, who use the money in my village? As soon as you give the PDM money like this, can I demonstrate? Today you will see young men with the bottles of beer throughout the night. Do you think this money is economic empowerment or it is a waste? I call it, many politicians fear to call it a waste in my district. I want to stand here as an advocate to say the economic, the empowerment, the mental change, the education that can leverage the person to know how to have the finance to be sustainably used. If we have not reached that stage, please don't give my people the money. Empower them first. Let them become the clinical profession. Then you give them title doctor. You give them title nurse. You give them title this. Unless someone knows how to keep this money for economic empowerment, please, why don't we go slow with the other processes first before we give the money.
Okay.
Then take the bottle. And it goes in GBV in your district. If you give it to the woman, she will not sleep in that house. Because the man will hand for that money. For money. For beer. For opium. Thank you very much.
Okay. Can you try to stand up? The one from the podium, you stand up. Now let's start with These questions are one of the papers. Allow me to read them verbatim so that when you come back to address us, we also take care of their questions. They are not going to say here. The first question is, Honorable Minister, the workers supported COVID-19 interventions are read the name of the person. The person is a teacher, is called Mr. Cassie. Okay, Mr. Cassie is saying, Honorable Minister, with the workers supported COVID-19 interventions, we are never recognized across the board by government. A letter of appreciation to each staff will be enough to us. And goes ahead to add that Honorable Minister, humble request for the Ministry of Health to strengthen working with the Ministry of Education to address health issues in schools, more especially issues around HIV, LGBTQ, suicidal behavior. Thank you, Honorable Minister. Okay, the last question is saying, Honorable Minister, humble request for the Ministry of Health to strengthen working with the Ministry of Education and Sports to address health issues in schools, more especially issues around HIV, LGBTQ, suicidal behaviors. Teacher Cassie. Colleagues who have listened attentively to the voices of the community and voices that many times have never heard. We think time has come for us to also listen to the Honorable Minister who will give ears and answers to some of these questions. But also, she has an obligation to launch a guideline that will implement the National Community Strategy. And this guideline was again an initiative when the Ministry of Health started working on the National Community Strategy. We said, no, how to wait. We need a guideline that will bring all partners on board what we present to speak in the one language. And that guideline, whether to launch it. But that will mean we will have to be patient a little because she will eat on our lunch. But Honorable Minister, the voices are saying what you speak to them is lunch enough. That is enough lunch. You nourish them into our more. You will take your time to answer, respond, and address the people. How I wish there were all of those. And that is waiting for another time. Honorable Minister, allow me to invite my director, Director of the Health, to come here and take the honor to invite the Honorable Minister to come and address the people. Let's give
Thank you very much. Honorable Minister, you asked me to seek democracy. That's why we now went for voting. Because if she starts speaking, it will end 2 hours. And if you want to hold lunch for 2 hours before we go for lunch, then you have to vote. You get democracy. You're going to win as you know. So, can we see by show of hands those who prefer first go eat and then come back and listen to the minister for 2 hours, or we listen for 2 hours, then go eat? So I am again. So these are 2 options. Please help me. Massive programs standing here. We are going to count. Because democracy, some people will not get their way. But we want to hear the majority view. Those who say we are going to fast, listen to the minister, she's ready. Then we go for lunch. And then those who ask that we must go for lunch, then we come back and listen to the minister. So I'll start with option 1. We go for listening to the minister first before lunch. The time check now is 13 hours. So those who want to go for lunch first, those outside, please do properly. Now, second option, those who want to fast go for lunch, go. Your majority, like this habits. I apologize if that is not properly, but we are growing. So now, after returning our assessment, I invite them outside to go for lunch and make sure you're back within 47 minutes so that we can have a chance to listen to all this. So, on our case, enjoy lunch. Can you stand up and bless the meal? Please pray for the meal. Praying, we are going to bless the lunch. Loving God, we want to thank you for the opportunity that we came here to discuss. Now, as we go for meals, they will be nourished, and the food will give us energy to serve you better, to serve our country better. In Jesus' name we pray.
So, my team leave the minister upstairs. You have lunch with upstairs.
I'm not even a member. I have just two months.
You are on the edge.
So, Dr. Mugagi, you leave the minister upstairs. Lunch.
Who participated in big culture. I'm coming, son.